Все, чек. Отлично. Чек. Дядь, я тогда отключаю пока его.
Шановні колеги, сьогодні в нас та зустріч, яка вже стає традиційною. До нас сьогодні приїхав один із найбільш знаних нейрохірургів світу, професор Джеймс Рутка з Канади, з Торонто, який робить дуже багато для української нейрохірургії. Це не тільки ті сучасні лекції, які ми з вами тут заслуховуємо, але й щире відношення до молодих нейрохірургів, запрошення наших молодих до візиту в клініку, госпіталь, який очолює професор Рутка. Ми щиро вдячні за цю діяльність, яка носить такий характер подвіжничества, я б сказав. І сьогодні у нас є декілька лекцій, які будуть прочитані не тільки професором Рутка, але й іншими фахівцями з Канади, Тетяною Ліпман. І з неї, з цієї лекції ми почнемо. Вони присвячені сучасним аспектам і канцерогенезу, і тим питанням, які є актуальними і нагальними для нейрохірургії. Я щиро вітаю наших гостей. Сподіваюся, що, як і завжди, їх візит до України буде приємним, продуктивним. Ну, а вони завжди в нашому інституті завжди є бажаними гостями. Привітаємо наших гостей. Ну і згідно з програмою, якщо ми її не міняємо, перша доповідь Тетяни Ліпман, Торонто, Канада, яка присвячена питанням генетики канцеру. Від молекулярної біології, як називається ця лекція, до спасіння життя. Що? Ваше? Ага. Ну, трошки деякі прості зміни. Я прошу, професор Костюк, Константин Романович, проголошуй тоді себе, будь ласка.
Гості, шановні, професор Джеймс Рутка, ми, коли планували цю програму, то що я виступлю з попередньою промовою і охарактеризую діяльність і вплив програми I would like to remind to our colleagues that that is the third visit of our Canadian friends of the Institute of Neurosurgery, which is a part of the program which called the Ukrainian Pediatric Fellowship Program. This project was started several years ago, and in this regard I would like to note to everybody that Dr. Miroslava Roma and Mark Bernstein, and a year ago by Professor and which could simultaneously again listened by all neurosurgeons in Ukraine via internet. And these lectures let us with neurosurgery, general neurosurgery, and especially epilepsy surgery as well. Also, during this week, Professor James Rutki helped us to carry out the first cases for open colostomy and for resection of focal cortical dysplasia by use of neuronavigation system. Now both types of these surgeries are routinely used in our neurosurgical practice, and our success and our results achieve us to raise our prestige around the neurologists and epileptologists in Ukraine. And to prove this information is that for the last years, around 80% of patients who were admitted in the Department of Functional Neurosurgery were sent to us by neurologists and epileptologists. Meanwhile, several years ago, there were only around 15 or 10 persons were sent by neurologists. Also, very important issue of the activity of Ukrainian International Fellowship Program is organizing of short observationship for neurosurgeons from all Ukraine to Toronto neurosurgical centers. Among them, 3 neurosurgeons from our institutions, as Volodymyr Fedirko, Ivan Procenta, and me, had a good chance to visit Захід Hospital and Toronto University Hospital. Without any doubt, I can say that these visits are interesting and very useful for each of us, because we have access to operating rooms, to intensive care units. We had a good possibilities to attend different medical which were held at that time in Toronto, and also we had a chance to take part in polyclinic consultations. Towards us, we feel comfortable during our staying in Toronto. All staff and people whom we met in Toronto were warm and open to us. Today we will listen to the lectures, and we had a great part with the modern achievements in pediatric neurosurgery, as well as achievements in recent researches in neuromorphology, neuro-oncology. Taking into account a great current, we suggest to Professor James Rutki several topics which, to our opinion, are very important nowadays, and to share his experience in these fields of pediatric neurosurgery. Also, I would like to know that research center in Захід Hospital is one of the well-known research institution in the world, where is going more modern genetic, immunological, morphological, and as well stem cell investigations. And the information which we will get now from Tatiana Lipman will be very interesting for us, and I do believe that this lecture will motivate our researchers to find some collaborations in different fields of that research. And in future we could join and be a part of some international program which is going in Захід Hospital. One more time, thank you for your visit of Kyiv, for your enthusiastic and willing to improve our medical care in Ukraine. And let me introduce Tatiana Lipman for her presentation.
Thank you. Дякую, Константин. Окей? Да-да-да. Ось така. Окей. Доброго дня усім присутнім у цьому залі. Хочу сказати, що це для мене велика честь виступати тут. І я ніколи не подумала б, що мені доведеться виступати у своїй рідній країні з промовою про мою роботу далеко за океаном. Я трошки хвилююся, але це дуже приємне хвилювання. So my name is Tatiana Liebman, and before I start, I would like to thank you, Dr. James Rutki and Dr. Miroslava Romach for this opportunity to be present here, for this honor to share my experiences of working at Sick Kids. I started to work there in 2007 as a technician in the laboratory of Dr. Kaplan, and we were working on neuroblastoma. During our research, we realized that the results and this study can be applied to the brain tumors too, and we started to collaborate with another doctor at Sick Kids, who is oncologist at the hospital for sick children at the same time, Uri Tabori, and slowly I switched to this laboratory, and we are now performing studies on pediatric tumors. And I'm going to, the goal of my presentation, the goal of my presentation actually to ignite interest between you surgeons into research and to show you that this is very important, that both institutions, Research Institute and a hospital, will be in a strong collaboration and relationship between each other. I briefly will show you two big projects in our laboratory that we're running currently, and I can assure you that this is not the only projects we are doing in the laboratory. It's just first step of our collaboration and our visits, and I'm sure that you will in the future hear many of fascinating work. So yeah, so many years humans are building bridges to unite two shores of rivers, to make their pathways safe and short in mountains, and of course to expand its area of living and of course knowledge of the world. And those bridges can be very comprehensive, simple, but they aim one thing, to unite people. And at Sick Kids in Toronto, this is how, I don't know why it's slow. This is the building of Sick Kids in Toronto, and this is how it looks. It's too slow. This is how look Research Institute, our new building that we are proud to work in, and it was open only 1 year ago, approximately 1.5 years ago. And this is how the bridge between these two buildings looks, exactly between Sick Kids and our Research Institute. And this bridge actually perform all of these duties of bridges. It saves our time when we need to run to our supervisors, which are doctors in the hospital, and they are always busy when run for the meetings to update them on our results in the laboratory. We resolve all our administrative issues, and it's really shorten our times. We also pick up samples from patients and bring them fast to the laboratory to process, extract DNA, freeze them down, and to move on with our work. All of this symbolic role of this bridge to bring together research and clinicians to improve and to rescue children's life. So my topic today will be the yin and yang of cancer genetics, from molecular biology to saving lives. I will present work of many people in our laboratory in and of our collaborators. So I will mention these people in this presentation, so it doesn't belong solely to me. I just was a small wheel in this big machine of research. So I will start with case 1 representation. 14-year-old boy appeared in the hospital with a massive medulloblastoma. His mother died of breast cancer at age 37, and grandmother had leukemia, and many other numerous members of the family had different types of cancer. We know that neuroblastoma has the survival of patients with neuroblastoma recently very improved. It's like 85–90% of survival, but medulloblastoma is famous for rapid recurrence and essentially result is death. The same happened with this boy. This is the pedigree family of this child. As you can see, each generation was affected with cancer. And this child was passed away from the tumor, and after his death, the tissue was sequenced for mutations, and mutations in the famous TP53 gene was found. TP53, the gene that's responsible for cell cycle, cell death, and it controls actually anti-cancer gene. Once it's mutated, it stops to function, and the cells become malignant and tumor develops. So once this mutation was found, and knowing the history of the family, the siblings of this boy were screened for this mutation as well. His sister Abella was screened, and as a result of the screen, the tumor was found in her brain. She went through the surgery, and now she's healthy without any chemotherapy, radiotherapy. So the conclusion of that, before we move to comprehensive research and comprehensive technique in DNA screening, searching for mutations, and driving mutations in cancers, the simple approach, clinical surveillance of families, especially those families that known affected by cancer, will lead to 100% of survival of those patients that went through the surveillance. This study was conducted by Anita Villani, master student at David Kaplan Laboratory at Захід, and she is also doctor at the hospital. So she found that those patients that went through the appropriate surveillance have a 100% of survival. Simple. So in our laboratory, we found that association of TP53 mutation with recurrence and survival in medulloblastoma patients. And we found that TP53 mutant tumors have almost no chance, patients with these mutations almost have no chance to survive compared to wild type, not mutant gene. And, but we accidentally read another paper from German group that found that there is no difference between, not significant difference between patients with a mutation in this gene and wild type, not mutant patients. And that was a little bit embarrassing to learn, yes? Like we did our study and we found this amazing result and we were proud of ourselves. And there is another group of scientists over the ocean that found no difference, and it's pretty stressful for scientists to learn these results. So, but as you may know, that there is recent studies by multiple groups, including Michael Taylor lab. Michael Taylor is also leading neurosurgeon in Захід, and his laboratory doing amazing search, and they found that there is they identified 4 subgroups in medulloblastoma based on expression profiles. And these subgroups differ in their demographics, they differ in their transcriptomes, and additional somatic genetic events and clinical outcomes. So different research groups also suggested different strategies to stratify these subgroups, and even propose different criteria how to assign these tumors to these subgroups. So currently, pretty much acknowledge that medulloblastoma is divided into 4 groups. Wind group, which has pretty good outcome and survival rate. Sonic hedgehog group, which has an intermediate survival rate, and group 3 and 4 that have the poor survival rate compared to 2 others group. So that led us to think that maybe this difference that we saw in screening in our hospital, in German hospital, that that division into subgroups can be key to find out the reason for these differences. Natalia Zhukova, at that time master student in our laboratory, conducted the research about that, and she hypothesized that survival of patients with TP53 mutations depend on molecular subgrouping, and she focused on beta-catenin, which is the gene responsible for cell-cell adhesion in our body and cell division. And it's also involved in a Wnt pathway in signal transduction in the cell. And we know that Wnt subgroup in medulloblastoma has a better survival. So we thought that there will be a connection between these pathways and differences in our studies. So here I shortly show that beta-catenin is proto-oncogene, meaning that mutations are found in different types of tumor, in between them medulloblastoma, GBM, and it was found that activating mutations in the beta-catenin genes is a universally favorable prognostic marker. So, and we found survival will exceed 90%. So, another study shown that beta-catenin mutations demonstrate better survival in the patients with p53 mutations. So we know that mutation in p53 gene leads to almost 100% death. But when these tumors have additional mutation of beta-catenin, the kids perform much better than those that have only p53 mutant gene. The same we see here, the staining of cells that show that those that have wild type, not mutant beta-catenin, they are positive for, I have to mention that this staining says that once we see these blue dots in the nuclear of the cell, that means that beta-catenin is not functioning, and when we don't see these blue dots, that means that this tumor will have favorable prognosis, and this is mutant beta-catenin. So there is another set of data showing that if you have wild type of, it's already done in our by our laboratory, and if you have mutant p53 and mutant p53 with beta-catenin mutant, you will have better survivals. And what was interesting to find that when we have Wnt mutant gene, which also controls cell proliferation, and Sonic hedgehog gene mutation, so there is a difference in survival, and that answered our questions why we have different results with German groups. So we contacted the group and we asked them to screen their patients that participated in their study for other mutations in other genes, and this is what they found, that their patients, their cohort, had Sony Hedgehog mutation, and our patients in our hospital had mutations in the Wnt pathway, and this is why we saw this discrepancy. That means that no one was wrong, the study was done appropriately in a high level accuracy, and it actually falls into this stratification system of 4 subgroups in the medulloblastoma. And we actually understood why it's happening. One of the contributors to this phenotype can be mutation in another gene. So Natalia hypothesized then, so if we will reactivate the Wnt pathway, so we may bring this TP53 mutant tumors from their 100% death to almost 100% survival. So she suggested that if we constitutively activate the beta-catenin signaling pathway, we will improve surveillance. And also we know that medulloblastoma patients go through the radiation that has its own side effects, and P53 tumors are resistant to radiotherapy. She suggested that also if we treat these patients with the lithium, we may sensitize these tumors to radiotherapy. And she was actually right. She used different cell lines, medulloblastoma established cell lines, to study her hypothesis. And those red lines, that she radiated them, and she found that P53 mutant lines were more resistant to radiotherapy than P53 wild type. And so when she studied cell lines which were P53 mutant and beta-catenin mutant, she found that they are all, just a second. She found that, yes, that catenin mutation rescue the phenotype and rescue cells from radiation effects. She also tested the effect of lithium treatment on the resistance against radiation, and she found that yes, those cells that, as you can see, the blue line is P53 mutant cells, and this red line, the cells that were treated with the lithium, and they had additional beta-catenin mutation. So you will see that vice versa. I did a mistake. The blue line is beta-catenin mutant, and they have better survival after radiation with the different doses of radiation. And striking results she got also, that when she compared how radiation influence on normal stem cells, brain stem cells treated with lithium, and she found that actually lithium protects normal stem cells, which is amazing results. That means that we protect, during the radiotherapy, we protect normal brain, and we target only tumor cells. And so the main conclusion from this study that she conducted, especially when we found these different subgroups of patients in Germany in our hospital, we learned that genomics can explain genetic events such as survival in P53 mutant patients, and actually apparently can also explain differences in survival in P53 mutant patients between different centers. And that brings again the issue that the more collaboration between different institutions, the better we will learn, we will know how to treat kids with tumors. And genetics can also add to molecular subgrouping of medulloblastoma. So now we know that we can, through the activation of the pathway inside the subgroup of medulloblastoma, we can significantly increase survival of the kids. And we also can use both together, develop novel therapeutics like combination of radiotherapy with lithium treatment that will protect normal cells. That was the main outcome of this study, and I brought it just to show you exactly how different countries, different institutions, long distances between them, collaboration with these groups can lead to fascinating results and fascinating outcomes. And I hope that this study is not ended yet. Just by publishing, I hope we will continue and we will treat kids in clinics with lithium and see what happens in clinics, not just on our dishes, in the tissue culture hoods in the laboratory. And my second case, which is a little bit bigger project now, and it's a new project just starting to develop. Case presentation number 2. 5 years ago, coming to the hospital with a neurofibromatosis type 1 symptoms, but with glioblastoma in her brain. And it is known fact that NF1 tumors, the patients don't develop glioblastoma, and that was a big surprise to doctors to see this child. This kid has multiple Kaffel light spots, which is a symptom of NF1 type tumors. But she may fill criteria for NF1 in her cognitive development, but appearance of glioblastoma was the factor that attracted attention of the doctors. And now we know that if your patients have one of these symptoms, family history of gastrointestinal tumors, normal growth despite of symptoms of NF1 tumors, they have normal growth, they have normal IQ, and there is a chance of consequency in the family, meaning that marriages inside the family. We are strongly recommending to pay attention on these patients because they probably will fall into another type of tumor, another type of syndrome, which called mismatch repair deficiency syndrome. Those cases are rare, and because those cases are not well studied and rare, there was created International Biallelic Mismatch Repair Deficiency Consortium that brings together countries all over the world, 14 countries. It offers free genetic counseling, and I emphasize on that because I will come back to that later. So free genetic counseling, genetic testing, management of patients and families, and it provides surveillance protocols and treatments guidelines, and highly inclusive and highly collaborative research. This consortium welcomes anybody, everybody to collaborate, and if there is a chance that you will find patients with such symptoms, Uri Tabori Laboratory undertake to assist financially in the shipment of these samples to our laboratory, and I will show all this comprehensive research we are doing on these samples. And the project is just started, it's developing very fast. We are overloaded with work, and we will be happy to collaborate because we consider it the biggest lab, the only lab in the world that has the biggest collection of these tumors, and we are talking about something between 40 to 50 tumors only, compared to thousands in neuroblastoma, glioblastoma. Only 50 tumors brings you to the top lab in the world. It's a rare case and it's interesting case. It's lots of things to study. So what is it mismatch repair? Briefly, I will just briefly show you that during DNA replication, mistakes happen. And there are two enzymes that are responsible to fix these mistakes. Pol E fix mismatch repair, meaning only one nucleotide mispaired with another nucleotide. It's a point mutation. So Pol E fixing leading strand of DNA and Pol Epsilon fixing the lagging strand. And there is a whole bunch of proteins that help these enzymes to fix mistakes. And among of them, most important 4 proteins that MSH2, MSH6 that initialize mismatch recognition, so they just see that this nucleotide is in the wrong place. And another set of proteins, MLH1 and PMS, there is a mistake, PMS2, catalyze repair process. And then all the machinery starts to work, and we know now that Pol E, all this complex, it's not just see the mutation, they fix mutation, and at the end they proofread. They confirm that yes, the DNA is fixed, and now cell can proliferate further. So this is briefly, and I just want you to remember that those 4 proteins that encoded by the same genes, MSH2, MLH1, and PMS2, they are most important players in all of this complicated system, even more complicated than it's shown in this slide. And the main player is Pol E, polymerase that does all the work. So biallelic misrepair deficiency syndrome, what is known about it? It's like Lynch syndrome. Brief comparison. Diagnosed at age of 47. There are like more than 5,000 articles about this syndrome. And we know that in this syndrome, it's cancer predisposition syndrome. There are mutations in all of these genes that I was talking in previous slides. What we know about BMMRD syndrome, nothing. There are only like 20, 30 papers in PubMed. We know that those genes, again, involved in this syndrome in kids. This is adults, and this is kids. We paid attention that there is differences. The most abundant mutations in adults in the gene MSH2, and in kids this is a less frequent mutation, and the most frequent mutation in kids PMS2, the less frequent in adults. And that one of the focuses to understand why, and maybe that's the key of all of this MMRD story, maybe not. This is and diagnosis at age 5 and 9. All these kids are getting nasty tumors, and they are actually very different types of tumors. This is clinical characteristic of these patients. Like 24 out of 25 kids will develop 42 tumors. All parents unaffected. They are just carriers of these mutations. The kids getting germline mutations in these genes, meaning that 2 alleles of DNA are affected and they cannot produce this protein. There's no replacement, nothing. So this is why probably they are getting these tumors. And also Lynch syndrome, this cancer predisposition syndrome, the families with these syndromes getting BMMRD more often. There is tumor spectrum in these patients, and as you can appreciate the amount of glioblastomas, low-grade glioblastomas, medulloblastomas these kids are getting, also gastrointestinal malignancies and polyposis and hematologic malignancies as well. So spectrum is very wide and impressive and very sad. So how we detect these tumors, the deficiency? First of all, the normal tissue immunohistochemistry is very essential for screening tool for MMR. And we are looking for this cafe-like spots, not only on the patients that actually can be misdiagnosed because they quite often thought to be birth spots that inherited at the birth, and this is why it's quite often misdiagnosed. So that's a very important tool for pathologists. Another way to stratify these patients is, for example, these 3 examples provide you like this patient had no evidence of recurrence during 8 years from diagnosis of glioblastoma, but recently this patient was treated with colon cancer. So this patient was thought to have glioblastoma, but no one knew that this patient is B-MMRD patient. And if that would known be ahead of time, of course, probably that child will get different attention and different therapies. This patient had multiple resection of polyps. This patient, 4 years of no symptoms of recurrence after glioblastoma, and then treated recently with T-cell lymphoma. So that's another category, another to put these patients into BMMRD, questioning BMMRD syndrome when they get multiple cancers. And another tool that was developed in our collaborator also at the Hospital for Sick Children, Christopher Pearson lab. He is the king of this functional assay that can detect these dysfunctional proteins, genes that I mentioned, like PMS2, MLH1. This is pretty complicated assay and labor. It requires lots of work and lots of knowledge, and you have to have appropriate lab and appropriate professionals to do this assay, and we collaborate with this laboratory and learning from them how to do that. And actually we are working now on other methods, maybe more that will together work with this assay to confirm the diagnosis, because it's very important to understand that this is BMMRD and those kids should be treated with the different regimens of therapy. So cancer predisposition syndrome cancers typically lack a unique mutational signature and therefore cannot be easily differentiated from sporadic tumors. And this is the consequence, as previously I showed, that kids don't show any symptoms of relapses and then they get other tumors. The additional hits required, we think that additional hits, only being MMRD, not enough to develop tumors, so they need the additional hits for malignant transformation in each of CPS, and the timing of such alterations, we don't know. We don't know when it happens. At embryonal level, straight after the birth, and okay, I will move to that later. And so we hypothesize that BMMRD cancer will have a unique signature which will enable us to detect cancers earlier and develop preventive therapies. What we think that preventive therapies are the key to treat these children and to determine these tumors, to define this syndrome in these samples. We use these comprehensive techniques, which like whole exome and whole genome sequencing, Affymetric SNP microarrays, and multiple additional functional and genetic assays on patient cell lines. We collaborate with Dr. Adam Schlein, also at Sick Kids, that just started a laboratory with very good professional in bioinformatics. Without them, this work couldn't be done. So our student, Brittany Campbell, recently started a PhD in our laboratory, and she is a leading person in this project. She's taking over learning bioinformatic part, and I'm helping her with our cell culture, animal in vivo work, and hopefully we will find nice results and fascinating decision will be made for these kids. So what she found, I won't go deep into this exome sequencing, all of this crazy world, but what she found compared to other tumors like childhood brain tumors, any other cancers, adult cancer, adults, she found that those BMMRD tumors, they are hypermutated. When you analyze, apply software, computer software to see how many mutations per megabyte of DNA, she found that those tumors are hypermutated. They are just on the scale, it's 1,000-fold more mutations than in typical low-grade gliomas, any type, glioblastoma, leukemias. They are exploding from the mutations. So there is another graph, the same data, just by another test, confirming that yes, those even age-related. You can see that other tumors like kids, child tumors, adult tumors, they doesn't matter what the age they are. Like we assume that the older person will be, the more mutation the person will have, the tumor that will have, but that's not true. It doesn't matter what the age of this regular tumors. The mutation rate will be much lower than those kids that age from 0 to 10 years old. They will have this overloaded with mutation. And also we were thinking, okay, so if it's germline mutation, that means that any cell in the body will be affected by the syndrome, and eventually any cell in the body will develop tumor. So we analyzed the normal tissue, the same patient, BMMRD patient that developed tumors. We analyzed normal tissue to see what the mutation status in these tissues, and we found that these proteins, 4 proteins, they are not functioning in the normal tissue, but we don't see any increased mutations in these tissues compared to controls. So as you see, no differences. So normal tissue in these patients don't have these mutations as tumor tissues. And that was also surprising to learn, because of germline mutation by definition, those cells should have mutations. So what we thought then, like what second event should happen in the cell that this normal tissue will transform to the tumor? And going through the literature and reading lots of papers about mismatch repair system in the cell, we've learned that actually there are several signatures in this syndrome in the patients with a mismatch repair deficiency that lead us to think that, meaning that there is preferable mutations in the genome, for example, C2T or C2T, the most abundant, or C2A. And when we went through the literature, we found that actually polymerase epsilon, polymerase E, if you remember my first slide about replication of DNA, this polymerase that is responsible to recognize, to fix, and to confirm that mistake is fixed. Actually, if there will be mutation in this gene, in POL-E gene, that means that these cells will have a high chance of developing, transferring to the tumor. So, and this is the Richard de Borja from the Adam Schlein that I mentioned before, our collaborator, bioinformatician. When we sequence about 50 samples that we have now, and he applied the software to unbiased hierarchical clustering based on mutation signature, based on the C2T, C2A mutations, he found that actually Pol E mutations fall all into one piece. So those BMMRD tumors, on top of that, they have all of these mutations. The tumors that preferably, if I can say that, developed in the kids with BMMRD syndrome, they all have Pol E mutation. So all these tumors, colon, high-grade brain tumors, and endometrial tumors, all of them have mutation in Pol E gene. And this is our main focus became in our study to learn how that will, whether this combination of BMMRD syndrome and Pol E mutation will lead to development of this nasty hypermutant tumors. Another slide shows that combination of these events will lead to hypermutant phenotype and eventually to develop the highly malignant tumors. So we screen tumors that don't have MMR deficiency and don't have Pol E mutations. Those are green tumors on the graph. We tested tumors that have only MMR deficiency, yellow in this graph, and tumors that have both, the red dots on the graph. And as you can see, the rate of mutations, the burden of mutations in the tumors that have both mutations, syndrome and mutation in Pol E, lead to the hypermutant phenotype, and that means that genome instability, and those cells will develop, actually eventually will transform to the tumors. This graph shows that we hypothesize, let's say this is, if we plot this data on this graph through the years, if you will put data through the time-wise, yes, so you will see that MMR deficiency abrogates some level of mutations, and we kind of hypothesize, okay, if we will observe these tumors longer, probably they will reach this point of mutations, like 10 to 2, 10 to 3 mutations per megabase of genome, whole genome. But if you plot these tumors that have both deficiency and Pol E mutation, they still higher than those tumors. They are way more further in their explosion with the mutations. And what we also found that no matter already how long the tumor will develop, for example, this BMRD tumor won't accumulate more than like 20,000 mutations per megabase of DNA. So probably they reach some level of this mutation that they cannot deal anymore with that, and it doesn't matter already what you acquire. You are malignant, you are exploding, and those kids actually have no chance for survival. So I will stop here because this project is huge and we have lots of data and we did lots of experiments. I don't want to move on with that because it's a little bit complicated and it was hard for me to decide at what point to stop. But what I wanted to show here, that we started this project approximately 2 years with a very preliminary results we got maybe 2-3 years ago or 2-3 months ago. And last week, a kid, female kid, I don't have details about the family yet, I just got this data 2 days ago, and I hope next week, during the week, I have more details about this family. There is a family with 2 children with germline mutations in this MMR proteins. So both of these children have GBM, high grade of glioblastoma, and they were treated in which is immune therapy. The drug called ipilimumab. Sorry for that. So she just started this treatment last week, and we hope that it's absolutely different from any standard treatment against glioblastoma, and we hope that we will see improvement, different outcomes, and we hope for this child. And as I said, with tremendous support of lots of people, different people at different levels, with this consortium I mentioned before. And again, I came to this yin and yang in cancer genomics. So what is that? Genetics and genomics and cancer, they are going together. They, as a whole piece, we have to study these things, but eventually I think yin and yang of biology of the cancer is bringing together research and clinicians. So this is the short information about this new drug, ipilimumab, that was FDA approved just recently for adults. And this girl is the only child in the world that is going to get this therapy. So we'll see, and I hope we will be able to update you on the results very soon. This is my laboratory. I can leave it for your pictures. Yeah. This is my laboratory. Uri Tabori. This is Brittany Campbell. All are great guys, very smart people, and you know what I've learned in Canada, that people there have warm heart, and they are ready to collaborate and help a lot. And I again want to emphasize that, going back to the symptoms, contact us, please. This is contacts of my PI, very easy. First name dot last name at Canada. If you will find patients like this, please, we will help with all the shipments, we will do all the work. And James Rutki just said that they are ready to bring scientists, not only surgeons, scientists, to learn, to participate in the study. And I think that will be fascinating for all of us if we can to do more research. We need more statistical data to say confidently that we are right, especially with this new approach of POL-E mutations. 50 samples is not enough to say loudly that our statistics are good. So please join us. And again, thank you for listening, and hope it was pretty clear, I don't know. Thank you.
Thank you very much, Tana, for your nice presentation. And now, while we are preparing the lectures for Professor James Rutki, I remind you that tomorrow you all who are interested in this research will get a chance to communicate with Tatiana to discuss different kinds of what we have had today.
Okay, so добрий день and щиро дякую to everyone. Thank you for a very kind invitation. Once again, it's a pleasure to be back at the Institute in Kyiv, and special thanks to Konstantin, who invited us and put this program together for us to share some of our presentations from Toronto with you. Special thanks to Professor Pedachenko for invitation to come to Institute. I should like to, at the very beginning, thank Professor Romak from Toronto, who has been very helpful in establishing this Ukraine pediatric fellowship that I'll be speaking about in some detail. Konstantin asked me to speak about several topics today. This is the first, intraventricular hemorrhage in pediatric population, and something that we deal with all the time at the Sick Children's Hospital. But first, we have Sick Kids Ukraine Pediatric Fellowship, and here is a photograph of Volodymyr Fedorko, who came to Toronto as part of this fellowship, and here he is being seen in Toronto in our special children's hospital. And of course, at surgery, he came to our operating room, not only at Children's Hospital, but at the adult centers as well. So, as Konstantin mentioned, many of you have come to Toronto. We look forward in the future to many more coming to Toronto. So first is about intraventricular hemorrhage, and what are the etiologies of this? Of course, the most important, I'll be spending most of my time on, is the germinal matrix hemorrhage. But you can get intraventricular hemorrhage also with trauma, arteriovenous malformation, aneurysm, tumor, infection, and it can be caused by what we do as surgeons and physicians. All these different types of etiologies occur. I'll speak at first about other types, then I'll get back to the germinal matrix. But of course, this is a hemorrhage from an arteriovenous malformation. You can see that this patient has already had surgery to remove partially the cranium, but also some of the intraparenchymal hemorrhage with this intraventricular hemorrhage. This is the angiogram, CT angiogram, is showing very large malformation that is seen in children. Children very frequently get arteriovenous malformation and bleeding, and sometimes the blood will occur in the intraventricular system. Another example, small arteriovenous malformation causing hemorrhage that you can see here in the ventricular system. Another case, Rolandic region AVM causing small amount of intraventricular hemorrhage as another example. But tumors can also cause. Here's a child who had a very unusual presentation with a lesion here and one in the parietal occipital area with intraventricular hemorrhage. Again, MRI scan showing hemorrhage that can occur in the intraventricular system. Trauma, another cause for intraventricular hemorrhage. You can see external ventricular drain in a child who had suffered quite severe head injury and has intraventricular hemorrhage. Here's an older child now, not neonate, but older child with a skull fracture that you can see here, and this child had a very severe intraventricular hemorrhage. And here you can see the amount of basal frontal injury that occurs after trauma, and frequently you'll see intraventricular hemorrhage. Aneurysms are rare in children, but sometimes they will cause intraventricular hemorrhage, as in this case, a rupture into the third ventricle will cause intraventricular hemorrhage. Here's CTA showing nice depiction of circle of Willis and aneurysm that you can see that will be associated with intraventricular hemorrhage. Some of the work we do as surgeons will also cause hemorrhage. Here you can see placement of a external ventricular drain associated with an intraparenchymal and intraventricular hemorrhage that can occur from time to time. This is a child who had anticoagulation and sinus thrombosis, but as a result of that, placement of the external drain caused intraventricular hemorrhage. And then removal of catheters. Those of you in pediatric neurosurgery doing shunt surgery, very frequently removing a catheter by itself will cause intraventricular hemorrhage. Another example of how just the sheer removal of catheters can cause hemorrhage in the intraventricular system. Here, of course, is a child who had neuroblastoma, a topic that Tatiana mentioned during her lecture. But this child was after bone marrow transplantation, coagulation disorder, and intraventricular hemorrhage that you can see here. So there's another example. This is post extracorporeal membrane oxygenation in neonate, very large intraventricular hemorrhage, iatrogenic, caused by the fact that this child was getting ECMO therapy. And so now we'll begin the discussion of the most common cause of neonatal intraventricular hemorrhage, which is abnormalities with the germinal matrix caused by preterm birth. So we know about the subependymal layer. It's a very cellular layer. It's very immature in the preterm infant, and it's a very vulnerable zone for hemorrhage because the vasculature is comprised of very thin-walled vessels, and as a result of that and the fact that they're not structurally intact, early on in neonatal life in the preterm infant, that can lead to ischemia and hemorrhage to occur. Here's an example of the histopathology of the germinal matrix. It's relatively immature in this preterm state, and then it grows to maturity later in neonatal life, but early on in the preterm infant, this can cause a source of hemorrhage. So this occurs in about 40% of the preterm births, more common in infants that are under 28 weeks of age, which is still very young. After age 28 weeks, we see it in the region of the caudate nucleus. We see them very frequently early after birth, associated with intraparenchymal hemorrhage and very high association with morbidity and mortality. Rarely it will be delayed, and oftentimes it's found in males more frequently than in females. Risk factors, as mentioned, under age 35 weeks, so the more early in life that it begins, under 30 weeks, you'll see interventricular hemorrhage. Low birth weight, of course, under 1,500 grams of weight is associated with a very high percentage. As you can see here, the percentage-wise decreases as we get up to 1,500 grams in weight, likely related to some of the parameters that are used for ventilation sequences when neonates are in the post-term basis, in the preterm life. Those parameters can often lead to this fragility of the hemorrhage, as is shown, and is a cause of perinatal seizures, coagulopathy, and many other disorders in the preterm birth state. There are maternal and obstetrical risk factors, and they include smoking, use of cocaine in some, multiple pregnancy, prolonged preterm labor and birth, use of contractive agents for the uterus, and absence of epidural anesthesia. All of these things are thought to be associated in preterm life with hemorrhage. So this is an example of how the hemorrhage occurs, and you can see the preterm brain, what it looks like, and the propensity for the hemorrhage to occur here in the region of the germinal matrix, causing interventricular hemorrhage, as is shown in this post-mortem specimen. Grading scheme, this is very important to understand, and this includes grade 1, which includes just the germinal matrix hemorrhage by itself. Grade 2, which includes germinal matrix plus interventricular hemorrhage, but no hydrocephalus. Grade 3, which is all of those, but now hydrocephalus. And the worst is grade 4, where you also have intraparenchymal hemorrhage. So grade 4 is the worst, associated with the worst outcome in terms of morbidity and mortality. And here's an example of preterm weeks of age, so less than 24 weeks, and then going up to 30 to 31 weeks. You can see that this is the highest incidence of grade 4, includes intraparenchymal hemorrhage for interventricular hemorrhage. And as you get older, you get less in terms of grade 4, and more chances then as the birth weight increases and as age increases of having interventricular hemorrhage. It goes down. These are some ultrasound images showing very small evidence of germinal matrix hemorrhage here that you can see on this coronal scan, but showing a fair degree of ventricular dilatation in this case. Here's some other examples, larger amounts of hemorrhage seen on these ultrasounds here. So ultrasound is one of the best screening tools that we use for neonatal hemorrhage and interventricular hemorrhage. We know that about 40 to 50% of germinal matrix hemorrhage patients will develop hydrocephalus. It's related to the amount of protein, debris that occurs inside the ventricular system, and inflammation of the arachnoid that develops afterwards. Less likely to occur in the low-grade interventricular hemorrhage, much higher in the higher-grade neonates. And it's proportional to the amount of blood that we see inside the ventricular system. And the most critical time is about 1 to 4 weeks after birth, when this is being followed, and determinations are made as to whether a neurosurgical treatment is required. And as mentioned, we usually use ultrasound, but we, on occasion, may use CT scan, and more frequently now we are using MRI scan. What are signs and symptoms for patients? They include increasing head circumference, fontanelle, which increases in its size and intensity, sun setting, eyes going down related to pressure in the tectal area, hypotonia, vomiting, pupillary changes, bradycardia, apnea, and seizures are all signs and symptoms may be related with interventricular hemorrhage. What are some of the treatment strategies? Sometimes pharmaceutical agents, but that's not so very effective. Lumbar punctures, we've used these many times, but I must say it's very rarely useful in the treatment of interventricular hemorrhage. We are tapping the fontanelle to bring down the size of the ventricles, also to relieve the amount of pressure that's there. That's a fairly straightforward procedure. Ommaya reservoirs can be used, especially in the very young preterm infants, where you want time before you would make determination about ventricular peritoneal shunt. You can use Ommaya reservoir access as a possibility for treating neonates with interventricular hemorrhage. And then, I don't know if you're using it here in Ukraine, ventricular subgaleal shunt. I'll show you a photograph of that shortly, but this is another technique of temporizing before you decide about management strategy with VP shunting. So pharmacology, as mentioned, not terribly useful. In pregnancy, you can use steroids, indomethacin. This is trying to increase the maturity of the lung system, but also to try to decrease the opportunity for germinal matrix hemorrhage. Of course, after birth, not a very useful strategy. Acetazolamide to decrease CSF formation. Same thing with diuretics like furosemide. Interventricular strategies. Sometimes we've been using this, so agents to decrease the amount of clotting in the ventricular system, to clear it from the CSF. We've used various urokinase type anticoagulation strategies and streptokinases as well. Lumbar puncture, it can be used. I must say, I don't think it's very efficient, very useful. These can be performed by the neonatal unit. The neurosurgeons aren't doing this typically in Toronto. It's done by the neonatal team. Temporizing measure, but frankly not very useful. And by the time you've done a number of these, there can be arachnoiditis in the thecal sac, and it can make the opportunity to do more lumbar puncture and withdrawing of CSF more difficult. This is what we use, which is ventricular taps, and this is usually done by neurosurgical service, and we do this usually at the bedside, and we can use the tapping using just landmarks and anatomical details to place a catheter into the ventricle and to drain CSF on a temporizing basis. Is not very useful on a long-term basis, as mentioned. So here's Ommaya reservoir. Of course, this is a useful tool to use for access when you're quite certain that you're going to need to remove CSF on a frequent basis. This we would do in the operating room, and we place this Ommaya reservoir, which will subsequently be tapped on a daily or every other day basis, and this can be a useful tool. And some of these children, after they are treated with Ommaya reservoir for several weeks, may not need a VP shunt, but most of the time they will be converted to VP shunt. Of course, here's example of the technology that's implanted for VP shunt. And in my own practice, I try to let the neonates get as old as they can be and weigh as much as 2 kilos before I will commit to a VP shunt. Because it's quite well known that under 1,500 grams, if you're putting in a VP shunt, the incidence of infection is very high. So the younger the infant, the smaller the infant, the higher the incidence of shunt infection, and that's really the problem. So of course we have many different techniques, many different valves to use, but in the neonate we would select for either straight tubing or very low pressure valve setting for treatment of neonatal interventricular hemorrhage. Now this is the subgaleal shunt that I mentioned to you, and some of my colleagues, I personally do not do this, it's not in my practice, but my colleagues at Sick Kids, some of them will do subgaleal shunting, and what that means is making a pocket that you can see here in the subgaleal space and connecting a ventricular catheter with a right angle into the space that's created in the subgaleal anatomic space, and there fluid will accumulate and instead of collecting in the ventricular system. And it's a temporizing measure, and some of my colleagues think this is useful. Personally, I have not used it, so I don't find it to be very helpful. But there are publications on the use of ventricular subgaleal shunting, and it is an option for you to consider for infants in whom you suspect may need to have a ventricular peritoneal shunt subsequently. And this is a technique to try to get more of a right angle going from the ventricular system here into the subgaleal space using this type of device or a right angle connector to keep it in the pocket. So what does the data tell us about outcomes in children after interventricular hemorrhage? There's been quite a lot written in the past. In general, in North America, I must tell you that the incidence of interventricular hemorrhage is decreasing as a result of two things. One, in the most important, is the perinatal care that's being provided in the intensive care unit. So we see less in the amount of interventricular hemorrhage than I saw when I started my practice 25 years ago by a wide margin. It may not be the same situation in Ukraine, but certainly in North America the incidence is decreasing. But we do know from a large series of patients who have been treated here, 335 patients, that 56% had normal outcome, but 20% had cerebral palsy, 12% epilepsy, 10% some form of cognitive disability. Of course, with grade 1, the chances of good outcome are better than with grade 4. Here you can see only 15% were graded as normal cognitive output. And look, in the grade 4, 70% developed spasticity as a result of the hemorrhage that they sustained. Another paper here from Developmental Medical Child Neurology, large number of patients. Here you had 83 patients with ventriculomegaly. And these ones you can see here with interventricular hemorrhage. At 8 years, they tested for motor visual intelligence, and no difference if the ventricles were kind of the same size and there was no interventricular hemorrhage. But in those that had interventricular hemorrhage, there was a lower IQ and in visual testing that was detected in those patients. So the presence of blood clearly has a role to play in outcome in these patients who have been born preterm. So that's a very important feature to remember. Other things to remember about outcomes, an older paper here, 75 patients or so, grade 3 or grade 4, so higher grade lesions for neonatal hemorrhage. And you can see mortality is based on extent of intracranial hemorrhage, number of shunt revisions, and birth weight, as I mentioned. And motor outcome is determined by grade of hemorrhage, birth weight, and whether there was seizure activity along the way. In this retrospective review of 52 patients with grade 4 hemorrhages, 37% survived, but almost 80% were below normal for intellectual function afterwards, and 60% had spastic quadriparesis. Many had chronic seizure disorders. And look at the cost of this in our society. This is now 20 years ago, but $150,000 it costs. So huge costs associated with interventricular hemorrhage and keeping children alive with this disorder. And there are some, obviously, that go on to lead normal lives and have normal cognitive outcome, but as you saw, the numbers decrease with increasing grade of hemorrhage. So it's a major topic and point of discussion in North America anyway as to how aggressive you are in treating the high-grade interventricular hemorrhages. And so the second reason why the numbers are falling off is that very active discussions with families at the time of grade 4 hemorrhage in preterm infants leads to very palliative measures and not active or aggressive therapy for very severe interventricular and intraparenchymal hemorrhage in grade 4 patients. So in conclusion, for this first presentation today, I showed you many different causes of interventricular hemorrhage that occur in children. The germinal matrix one is, of course, the most important and where I spent most of my time speaking to you today. It's highly cellular, it's a fragile vasculature, and as a result is prone to hemorrhage. We talked about the extent of prematurity that correlates with the amount of hemorrhage that can be there. And I also mentioned to you what birth weight that I choose then to select for inserting a VP shunt. Usually it's around 2 kilos. If I can get a baby to 2 kilos, I'm considering then putting in a VP shunt if it's required. We have a number of different treatment modalities. We have surgery, which is the mainstay of treatment for truly progressive interventricular hemorrhage. And as mentioned to you, the higher grade interventricular hemorrhage has the worst outcome. So with that, that ends the first lecture for this morning, and I do wish and hope that we will see many more of you coming to Toronto in the future on this fellowship that we have. Here's a photograph of Konstantin and his lovely wife Katerina, who came to Toronto as part of the first wave of Ukrainian neurosurgeons from this institute, and I hope in the future we will see many more of you coming on observership fellowship to Toronto. Thank you for your attention for this presentation. So I'll pull up the next presentation, but just while we are doing that, any questions on interventricular hemorrhage from audience? Anybody wish question? Yes, Ivan.
Dear Professor, thank you very much for a very interesting lecture. And I'd like to ask you what was the minimal age of neonate with interventricular hemorrhage in your department, and what minimal weight was by the moment of insertion of shunt?
Thank you for your question, Ivan. So one question was related to age, minimum age that we may see infants who come to our department with hemorrhage, and when do we put in, what is the weight of insertion for VP shunt? And we've seen amazing cases of survival after interventricular hemorrhage in neonates born preterm as young as 24 weeks. 24 weeks we have seen, and they have small amount of interventricular hemorrhage, treated aggressively, not shunted until about 28 to 30 weeks is what we usually wait. But again, the weight to me is more important. So if I can get between 1,500 to 2,000 grams, so almost 2 kilos, I feel very happy about that. So we will do temporizing measures, as mentioned, whether it's Ommaya reservoir or the ventricular subgaleal shunt, until we get to that point where we feel satisfied that they are mature enough. Because once you start down the pathway of shunt infection, it's a very hard problem, very difficult problem, because then you get loculated ventricles, then you get multiple shunt systems required, then we know that cognitive output in development is worse. So we're very careful not to put shunt in too early for those reasons. So thank you for your question. Yes, question here.
Thank you very much for that presentation, Professor. What do you think of brainwashing procedure?
Brainwashing technique. So thank you. So Professor from Kharkiv is here and asked a nice question about the irrigation of the ventricular system, trying to clear out the blood. So we were part of a study that looked at using urokinase and streptokinase to dissolve the clot and then to irrigate the clot to make it come away more quickly. But in the end, and after now a number of multi-center studies, this does not appear to be a very predictable technique, and also the outcomes have never been shown to be better than outcomes using the strategy that I mentioned. So although we have it and we use it sometimes for massive interventricular hemorrhage where the entire ventricular system is filled with clot, for most usual cases that are much smaller than that, we don't use washing technique very often, but it is a strategy that some centers will use, but at Sick Kids we are not using it routinely. Yes, question?
Michael, dear Professor, could you say what are the indications for open neurosurgical interventions in the cases of such sort of bleedings, ventricular bleedings? I mean, direct clot evacuation, endoscopical technique, decompression. So, what are indications and what are results?
Yeah, so the question was related to when would we use open procedure to evacuate the clot, like a physical extraction of the clot to make the amount of blood clot less, hopefully to alter the outcome. I think we've used endoscopy rarely in children this age in Toronto, and again only for massive bleed, as was mentioned in the previous question, where we have a huge clot filling the entire ventricular system. We might be tempted to use endoscope to remove clot in that basis, but very difficult from a single approach to remove clot in both ventricles. You can do it if you remove clot and do a septostomy. But remember, this is in a very vulnerable brain population where the brain is not very mature, and any of your open approaches can lead to hemorrhage in the brain itself just through access. So it's very tough to operate on the neonatal brain. We operate on the full-term infant brain all the time, but in the prenatal instance, born preterm, the brain is really vulnerable to open approaches, and we would use open approaches very rarely. And one more question here.
Thank you, Mr. Professor, for an interesting report. I just would like to ask about the method of prophylactics of intraventricular hemorrhage in the children in your department.
So prophylactic intervention of intraventricular. So how to avoid so it comes down to maternal measures, what you can do to try to boost maturity when a woman is going into preterm labor. How do you stop that from happening? And that's more an obstetrical question, but basically lots of techniques to try to improve lung maturity, because it's the prematurity of the lung system that then places the neonates on ventilators, and the ventilator systems that are used now have changed dramatically to try to reduce the pressures that are felt by the brain that would then cause venous raised pressures that then cause intraventricular hemorrhage through germinal matrix. So those strategies are used to boost lung maturity before birth. And then there are some medicines, as I mentioned, like corticosteroids and other agents to try to avoid preterm birth. But the longer, in maternal sense, a woman can hold on to her pregnancy, the better the outcome will be if the child can go to maturity. And of course they're being measured and monitored by ultrasound and even fetal MRI now to really determine what their chances are of having hemorrhage if they're born preterm. I think in interest of time I'm going to go on, and there'll be other questions, other people to ask questions. So this next topic is biology of embryonal tumors. And this is a very interesting topic because these tumors are rare, but because they are so rare, they cause challenges for the treatment team because not so much is known as to how we take care of them. So what am I talking about? What are embryonal tumors? And they come down to the following. Medulloblastoma, about which I will not be saying much in this presentation. I think I've been to Institute previously to talk to you about medulloblastoma, but I will be talking about this tumor, which is called CNS PNET. PNET stands for primitive neuroectodermal tumor, and ATRT stands for atypical teratoid rhabdoid tumor. So these two tumors, as you can see, only comprise about 8% to 10% of entire pediatric brain tumor spectrum, so very rare tumors. And until recently, we had no markers, and we really didn't know what caused these tumors. But now, thanks to the research that Tatiana Lipman presented in her presentation earlier, you will know that we have opportunities to make diagnosis of these tumors, even though when we look at these tumors under the microscope, they look similar to other tumors of the brain. So we have some clinical challenges for these tumors. They're heterogeneous. They're associated with poor outcome. Most of the children who develop these tumors are young, under age 3, and that's one of the problems because one of the salvage strategies for malignant brain tumors in children, which is radiation therapy, cannot be used frequently in this patient population for reasons we can discuss. There are many biological challenges here that you can see, but we'll talk about these as we go along. So here's a slide that tells you the difference between primitive neuroectodermal tumors and medulloblastoma. So medulloblastoma is the most common malignant tumor in childhood of the brain, but these are very rare that you can see here. Look, age of presentation is much less. They are much more heterogeneous in terms of the way they appear on imaging studies. Differentiated on histopathology. This says no chromosomal abnormalities, but now we know that's not true, and I'll share some of the recent research at Sick Kids Hospital and elsewhere around the world that has now shown what some of the markers are. Metastasis about the same as medulloblastoma, and we try, where possible, to do surgery, radiation if the child is old enough, and chemotherapy. But prognosis, look at the difference in survival between PNET and medulloblastoma. About half the survival rate for these tumors, so they're very difficult tumors for us to treat. Here are some imaging features showing you how challenging these tumors are as surgeons to approach. Here's a PNET that goes supratentorial and infratentorial. And as mentioned to you, most of these will be found in or around the pineal region. And my last presentation today is on pineal region tumors, so I'll talk about approaches to pineal tumors later. But here's an example of PNET in the ventricular. Here, large PNET going from infratentorial to supratentorial, very difficult tumors. And because they're small children mostly, poses challenges to the neurosurgeon and the neural anesthesiologist. Example of a supratentorial PNET, very heterogeneous in the way that these tumors appear on imaging studies. And as mentioned too, the epicenter frequently is the pineal region. So these tumors can be approached by surgery using pineal region approaches. So our long objective has been to try to determine the molecular biology of these tumors. And so my colleagues in Toronto, Dr. Tabori, with whom Tatiana works, but also Dr. Huang in Toronto, also Dr. Hawkins, have studied these tumors now, and we have established a global collaborative tumor bank where we're looking at these tumors worldwide. And so we've got over 300 tumors now of these rare tumors. So the important thing for you to know from this discussion today is that PNET has a defined subgroup now that's well recognized that breaks them into 3 different groups. Depending on whether they have these markers present. The markers I'm talking about, OLIG2 and metastases, whether those are present put you in group 2, and group 3, where it's absent or where metastasis is in the order of about 60%. And you can look at the age difference between group 1, group 2, and group 3. Group 1 has an appearance here very early in age, where group 2 occur a little bit later in age group. And the other very important point to know now is based on the work by Dr. Huang, there's a microRNA now known as C19MC, which is the most important molecular feature that distinguishes group 1 PNET. And here you can see that this particular tumor is universally fatal. If you have C19 microRNA, your survival is the worst compared to no amplification of this particular microRNA cluster. So that observation has now led us to really make good discussions with the family. If we see this and we know that it's happening, and if we know that they don't have this cluster, we can have further discussions about aggressive therapy. But this one, despite all of our best efforts, has the worst prognosis of all. So treatment generally is surgery for the first approach, followed by, and it could be either gross total resection or subtotal resection. We try this to establish a diagnosis, to overcome disturbances in CSF and to avoid use of shunting. If a child is over age 3 and preferably age 5, we will consider using radiation therapy. This is the dosing of radiation therapy that we would consider to the primary site. But because these tumors are prone to metastasis, we must use cranial spinal irradiation to this amount. And that's why we need older children. And chemotherapy is comprised of these agents typically. And we've been using high-dose chemotherapy with stem cell rescue. And I think in Ukraine you have opportunity in some centers, probably not very many, to use stem cell rescue therapy for children who have these very aggressive embryonal tumors. What's the prognosis? I mentioned already that the 3-year survival is worse than medulloblastoma. This one is very bad, universally poor prognosis, this microRNA cluster amplification that was discovered by Dr. Huang at Sick Kids Hospital. And it's because these tumors disseminate into the ventricular system that they have such a very poor prognosis associated with them. Here's a child that I treated at Sick Kids Hospital. Look, at time of presentation, this was a 3-month-old baby at the time of diagnosis. You can see hydrocephalus. You can see the tumor here in the trigone of the lateral ventricle and this large posterior fossa tumor. So this one occurred in 2 separate places, and of course this one is indicative of a different tumor that's called atypical teratoid rhabdoid tumor, or ATRT. Initially this was thought to be part of Wilms tumor, but it's now known to be a separate tumor with a separate genetic predisposition. They're found mostly throughout the body, in the kidney and the brain situation. But in the old days, these were thought to be medulloblastoma, but now we can separate these from medulloblastoma, and we know they are called ATRT tumor. Interestingly, when I was a young faculty member in 1994, 20 years ago or more, we published one of the first papers. At that time it was called malignant rhabdoid tumor. Now we call it ATRT, but back in those days, we discovered this tumor in the pineal region tumor. This is the child who presented to me. We went supracerebellar infratentorial to remove this tumor. We had a good resection, but because the child was a very young child, under age 3, could not get radiation therapy, relied on chemotherapy, and the child recurred after surgery with, you can see, very, very extensive tumor around the brainstem at the time of progression. So it was associated with a very short survival. We tried to culture the tumor from surgery, and here you can see the light microscopy of a malignant rhabdoid tumor in culture, and we showed that these tumors have a very high percentage producing type 4 collagenase to induce invasiveness of these tumors. But we now know that that's only one of the things that's important for the diagnosis of pineal region tumor. There's a genetic defect, I'll talk to you, that really allows us to make the diagnosis in more detail. So most children, again, under age 3, posterior fossa is the most important site. The supratentorial site is rare in infants, but is seen more frequently as children get older. Look at the young age of diagnosis here for these ATRTs, slightly more common in boys, and again, very rare tumor. We see them more often in infants than in children. And this is the diagnosis. So this is the HSNF5 gene that was initially identified. It's also known as INI1, also known as SMARCB1 mutation. So this is a tumor suppressor gene, and when it's eliminated, it causes this ATRT tumor to be formed. And it can be familial, and we now know there are many families in which this mutation occurs. So presentation by age, more likely to be metastatic. 63% are found below the tentorium, often in the genetic forms that occur in families. Patients will have renal cancers as well as brain cancers, so that's a very interesting observation for these tumors. And we are distinguishing these from medulloblastoma on the basis of the history imaging, but now on the molecular features as mentioned. So here are some examples of the imaging. ATRT here, what it looks like in the posterior fossa. Heterogeneous enhancement occurs. They have iso or low signal on T2. They can have cysts, and hydrocephalus is frequent, and leptomeningeal spread is very, very common. So just like medulloblastoma, they're hyperintense on the T1 MR, which gives them a hypercellular appearance at the time of pathology. Some more imaging that you can see here. Look at the large region often occupying the area of the pineal area. Other imaging here, another posterior fossa type, quite extensive tumor going into the CP angle that you can see out the Luschka. And this is the case that I presented at the very beginning. In the trigonal lateral ventricle here in the posterior fossa, you can see 6-month female, tense fontanelle, milestones were regressing. We inserted a shunt. Then we did a posterior fossa craniotomy, took out this tumor, and then we took out the occipital tumor, went on for chemotherapy. Very sad thing about this case was this child had aggressive chemotherapy and stem cell transplant, and as a complication of the medical therapy, the child died from the chemotherapy, not from the tumor. So that's a very sad situation. This was our after surgery. You can see the nice resection that we had achieved, but as mentioned, after several doses of chemotherapy, and the challenge of chemotherapy with stem cell rescue in this population is that they become cytopenic, they have hemorrhage, they have problems with their cardiorespiratory system, and as a result, this was a very sad consequence. And this was a photograph of this child before death after chemotherapy. You can see the young age of these children, but we have some survivors now. Maybe 10 years ago, we had no survivor of ATRT. Now we have some survivor of ATRT. 70% of cases look like, to some degree, like small blue tumor, like medulloblastoma, but they have these rhabdoid inclusion cells, sometimes difficult to differentiate from choroid plexus carcinoma. But the most important thing now, by immunohistochemistry, which you probably have in Ukraine now, you can do for this SMARCB1 or INI1 gene mutation, you can now look for loss of this in immunohistochemistry to make the diagnosis. So here, for example, is what the tumor looks like by pathology. Here are these large rhabdoid cells that you can see on pathology, but the way you make the diagnosis now is by this INI1 SMARCB1 negative. So Where the brown cells are positive, those are in the blood vessels, but the tumor itself is negative for this stain, which means that this is a tumor suppressor gene that's been eliminated. As a result, ATRT forms in this location. So that's on chromosome 22q. That's the name of the gene, as mentioned there. Up to 50% will have germline mutations. All of them are almost new mutations, but there are some family examples, as I mentioned to you. This particular gene, if you're wondering, is involved in chromatin remodeling. We know that in animal models, if you eliminate the expression of this gene in animals, they will get ATRTs. And now we have a test to look for this and the mutation for it in various protocols in North America that we are using. This world has moved ahead very quickly. This is from 2015, and here's subgroup analysis of atypical teratoid rhabdoid tumors, integrated genomic and clinical pathological analysis. Annie Huang, who's from Sick Kids Hospital, is mentioned in this paper, as is Dr. Buffet, our lead neuropathologist, and many, many others who were to this paper. And it led to a commentary on, now we know we can subdivide rhabdoid tumors into at least two different subgroups, group 1 and group 2, based on whole genome sequencing, methylation analyses, and gene expression. Group 1 and group 2 are found as different molecular subtypes of ATRT. Group 1 and Group 2 really, in early studies, didn't have much in way of differential survival rates, but now we know that Group 1 survives longer than Group 2 based on various analyses that we've done genetically. And we can subdivide patients with Group 1 and Group 2 into high risk, sort of intermediate risk, and low risk groups. And this helps us then, we think, in the future, although survival is still very poor, to think about treatment strategies for patients with ATRTs. Just some of the other features about the molecular genetics in this table. I know you can't read it, but what I'm summarizing here is that the age, tumor location, stage of disease, extent of resection, chemotherapy, radiation therapy, all now can play roles in subdividing patients into Group 1 or Group 2 and indicating survival rate, although survival advantage is just slightly better for Group 1 than Group 2. This is fluorescein in situ hybridization showing monosomy for this SMARCB1 gene on chromosome 22 when compared to control. So the one dot indicates loss of expression of the gene of interest here that you can do in the laboratory. So just like with supratentorial PNET, surgery is first step. We try to be aggressive with surgery. There's some data to suggest that extent of resection helps with these tumors. But remember, you're operating typically on very small children. Radiotherapy, craniospinal if they're old enough, of course. Chemotherapy to delay radiation is sometimes used. And then there's no standard treatment for babies yet, but we push hard with surgery and with chemotherapy. And if we're so lucky that they survive to an age when radiation therapy is possible, we might delay radiation therapy. But we have some survivors now, very few, but some that have been treated with chemotherapy alone and are still alive in good condition. I'll just very briefly tell you about some research that we're doing into ATRT tumors. And so here we have the SNF5 gene that we're deleting in our mouse stem cell delivery system. We're able now to isolate stem cells from the mouse brain, infect them with various oncogenes and tumor suppressor genes, and trying to develop a mouse with a tumor that has ATRT. And there are now a number of cell lines, most of them have come out of Los Angeles, that we can insert and implant into the mouse brain and then treat with various strategies with the chemotherapy and radiation to see if we can come up with a better system for treating the mouse based on these cell lines. But it's not as good as developing your own mouse model system. So we're in the process now, and we're very close to developing an ATRT mouse tumor, brain tumor, which we hope will be very helpful in the future for modeling brain cancers that will allow us to come up with better treatments for children that have this disease. So in summary, just like in Tatiana's talk, for these embryonal tumors, we have genomics and cell biology. We have the patient data now that are helping us to put patients into high-risk groups, like for PNET, on the microRNA cluster here. And then for ATRT, I already talked to you about the HSNF5 and the INI1 gene mutation. This is the laboratory where Tatiana works, and all the number of individuals working in the Arthur and Sonia Labatt Brain Tumor Research Center. Now we have over 100 people just working on the problem of brain tumors, so it's a very big group. And here we have a beautiful photograph of Ivan, who came to Toronto and on fellowship with a friend, Ihor from Lviv, a neurosurgeon, also coming. And so we really hope that in the future we'll be able to support more coming to Toronto to enjoy a fellowship situation like that. And then while it's not all work, I just want to point out on occasion we do some other interesting things. And here Ivan has seen very famous scenery in Canada. This is Niagara Falls, in case you don't recognize. That's the American side of Niagara Falls here, with colleagues from Lviv as well, neurosurgeons all coming to Canada. This was in December, so it was a little bit cold, but not snow on the ground at that time. So with that, thank you very much for your attention for that presentation. Okay, so I think we're doing okay. We'll have just a moment if there's other questions on embryonal tumors. I'd be very happy to answer before we move to next lecture presentation. Any question about PNET or ATRT tumor? Ivan.
Dear Professor, thank you very much for your report, helpful for both neurosurgeons and pathologists. And we know about four subgroups of medulloblastoma discovered in your research lab. Can you think of the similar subgenetic subgroups in terms of PNET?
So, so the question is are there separate subgroups for PNET? And not so clearly defined, because we have not identified so many tumor specimens of supratentorial PNET. But we have evidence to suggest now that there are at least 3 subgroups, but only 2 of them are clinically validated at this stage, group 1 and group 2. And the group 1, as mentioned, has the marker of the C19MC microRNA cluster abnormality associated with it. I think there'll be other genes that will come out of future analysis with in-depth whole genome sequencing analysis, but at this stage, we're not quite as advanced as we are for medulloblastoma, understanding subgroups for PNET, but we're certainly getting closer than where we were 5 years ago. Okay, thank you. Okay, Konstantin.
How can you explain the tumors growing the baby's brain is so complicated to permit to rise the tumor for so?
Thank you, Konstantin. So I think the question was related to how could the tumors be so big in baby? How do they get to be so large before diagnosis is made? And you know, we're even able now with antenatal testing, so before babies are born, to do in utero MRI scan, and we've diagnosed brain tumors like they're probably reaching that size of mass within 3 to 6 months. So within a very short time, they grow from almost nothing to a very large tumor. But there's a possibility, of course, in a very young child that these tumors start in utero due to abnormalities related to duplication errors in the genome, and also genetic tendencies for some of these tumors to arise in utero. And then after the baby's born, of course, it continues to grow, so that by 3 to 6 months of age, these are very large tumors, as you asked the question. Yes, Tatiana.
So, as a result of this tumor in the uterus, is there any relation with the mother? What's her health status?
So Tatiana's question, is there any maternal relationship between the cancer in the fetus and in the fetus cancer itself? And so we just haven't done that many genetic tests looking at fetal brain cancers, comparing them to genomic analyses of mothers, the maternal side. But that obviously should be done in the future. For ATRT, for sure, there are familial cases, and we know that somewhere in the germline it's passed down from family member to family member. Yeah, question at the back.
Thank you very much. Can you tell us, are there any data about the individual tumor's evolution? Once these mutations have happened, but maybe due to the growth of the tumor and development, some mutations can also have change in their resistance to the therapy. Are there any data about this?
So the question is, can the tumors change over time? Let's say you have an effective therapy that looks like it's promising initially. Yeah, that's one of the big problems, actually, is that tumor cell resistance occurs, and even if one strategy, one chemotherapy drug is thought to be useful, the resistance mechanisms build up in individual cancer cells and can lead to a different population of tumor cells that can then grow and cause relapse or recurrence of the tumor. A completely different strategy to treat those tumors. Okay, last question here, and then we'll go on.
Dear Professor, thank you for your interesting report. I want to ask you, if, as I understand properly, you haven't got any particular tactics of treating the babies. I want to ask you, what do you personally think about the treating babies? What is the tactic? Have you got any tactics personally?
So I think the question is more related to strategies that are specific for babies, neonates, young children, because they're a vulnerable population, and their treatments can be very strong and harmful. As I mentioned to you, I showed you one example of a baby who died just from chemotherapy. So you really need very good neuro-oncologists helping with balancing the toxic effects of the chemotherapy with what the baby's system can withstand. And so we have very good trained multiple neuro-oncologists in Toronto who are paying attention very closely to the side effects of the medication, which can be very difficult and challenging. But the biggest challenges for the medications, the chemotherapy, include the immune suppression. I mentioned the cardiorespiratory system, so we have to watch the dosing so that they don't accumulate so much that their heart and their lungs are affected by the chemotherapy, because then they can go into a system or a process that's known as multi-system failure. They can become very sick from that. So it's a challenge to treat these young infants because of their small size and the attack on the immune system, but we've been successful. But as mentioned, we've also had some side effects and consequences related to these very aggressive treatments. Okay, so I'm going to move on to next talk. I think we'll try to finish, as mentioned, by 12:30 for everything. This talk is a little bit futuristic, and so I'm talking about where are we going in the future for brain tumor therapy. So we know that big data, that means the accumulation of information from the internet and what can be done in bioinformatics that Tatiana talked about, novel technologies that neurosurgeons are always interested in, and personalized medicine are going to pave the way for the future for us. In neurosurgery, we have all these tools from MRI, functional MRI, MEG, diffusion tensor imaging, and I'm showing you all of those on one MRI scan here in a child who has a brain tumor in this location. And so we can remove tumors that are up against the cortical spinal tract now using all of these technologies as safely as possible. Here's a child who has a thalamic tumor that you can see here. This child also has neurofibroma NF1, neurofibroma type 1 that Tatiana mentioned. And this was a very brief history. Here you can see the cortical spinal tract around the tumor. And we approached this through a transcortical technique, but we used neuronavigation, NICO myriad system, and we resected this tumor, and here's the post-operative result. You can see tumor removed, and here's the child 1 year after surgery. Unfortunately, I'm sorry, video is not playing, but you have to trust me on this. She's running up and down the hallway on this one after surgery. So we can do surgery. Here's a dominant sylvian epidermoid tumor. You can see in this location here. So this would be typically where language would be located in most right-handed people. Here we are removing this dermoid in this teenager. Let's see, maybe will this play? Yeah, I'm very sorry. It doesn't look like any of my videos are playing on this system, so I apologize. So we published this in the Journal of Neurosurgery Pediatrics, but using very careful neurosurgical technique, we were able to remove a tumor like this even from the very critical area. And here's the removal of the tumor that you can see, epidermoid tumor in the sylvian region. Okay, I'm hoping this video will play. If not, I'll see if I can find it for you. So this is a small third ventricular tumor in a child who had a posterior fossa resection for astrocytoma. The tumor is located right here. It's very small in the third ventricle. And let's see if we can get this video to play. If not, I'll see if I'm lucky to find it for you. No, not playing, so I apologize. Maybe I can find it in one second. Okay, so this is the video. I'm sorry, I don't know why my videos are not playing. It must be system problem, but there's the lesion you're seeing in the third ventricle. There's the anterior commissure, that's the massa intermedia in front. There's the tumor. Soon you'll see us taking biopsies of the tumor that's there. Then we'll bring in this Myriad device that we will use to resect the tumor through the endoscope. This is done endoscopically, removal of tumor. So there we're taking a sample of the tumor in the third ventricle. And then this is the Myriad device that allows us to use the endoscope, and then it's like an ultrasound aspirator almost, but it's a mechanical device that resects the tumor through the endoscope. There you can see the aqueduct of Sylvius in this location. A beautiful view. And then we're taking the tumor out almost completely, and this was a low-grade tumor that we were able to remove. So that's advances in our technology allowing us to do nice surgery like that, but we also have awake craniotomy that's being used. I think in Ukraine you're using that now more and more. We have intraoperative techniques including perfusion, MRI, and even in young children. We can do awake craniotomy in children as young as age 4. We've done that at Sick Kids Hospital. But we've seen a whole revolution going from the DNA through to patients with genetic disturbances all in the course of 60 years, which is really remarkable on this genetic journey. Well, we do know that the number of coding mutations in cancer is about 35 total. In lung cancer, we have 125, but GBM has about half that number, so in adults, about 60 mutations per tumor. Pediatric cancers have fewer mutations than adult cancers, and this is especially true for brain tumors. These are the number of driver genes, the number of tumor suppressor genes, and oncogenes in any given cancer. And we now know that there are 12 core cancer pathways, and I'm listing some of those pathways here. So there are way more cancer mutations, but fewer pathways. So if we can target the pathways, we may be in better shape to treat cancer than if we try to target all the mutations, of course. So I envision a day, and Yvonne asked the question about subtyping of tumors, and here's medulloblastoma, and we can clinically stage these tumors now, but I predict we'll be operating on patients with tumors like medulloblastoma. We'll be doing molecular subtyping, and we'll have different treatment groups, and we'll have very specific therapies for each of the treatment groups. You heard about the Wnt and sonic hedgehog groups from Tatiana's lecture this morning, and we think that'll be the case in the future. We have many different ways in our research laboratory of looking at brain tumors. These are just some of the techniques that we're using to do very in-depth detail and profiling of our tumors, including down to whole genome sequencing. All of these different techniques are being used to characterize the tumors. Here's a little bit about medulloblastoma. We know it's the most common brain tumor in pediatrics and has a slight male preference. Here's the tumor that you can see in the posterior fossa. And this is a very common tumor that we approach all the time in pediatrics. Here's an 8-year-old male. This is an example of medulloblastoma. Here's his tumor prior to surgery. You can see filling the fourth ventricle here. Very obvious to all of you in the audience. These large tumors can affect children. After surgery, you can see we achieved nice resection. He had a complete removal of the tumor. He went on to get cranial irradiation and chemotherapy, and now 8 years later, he's alive and well. Here's the patient. This is Julian and his family. This is at Sick Kids Hospital in one of our events in celebration of survivors of cancer. But they all have these problems related to their treatments, including surgery, radiation, chemotherapy. So ataxia, hearing loss, endocrinopathy, cognitive impairment, poor socialization, emotional ability, altered family dynamics are possible. So the best current treatment that we have for medulloblastoma includes safe neurosurgical resection, radiation therapy, especially under age 3, chemotherapy, and we can expect survivals of 80% in our standard risk group and 60% even in the high risk group. So that's twice the survival, if not more, than for the embryonal tumors that I saw earlier this morning. So how can we improve survival? Well, one way to do it is to improve our understanding of the genetics. And for medulloblastoma, we know now that it is a genetic disorder that has segregated the tumor into 4 different subtypes. Here's 4 papers from Nature in 2012, and one of them here is from our group in Toronto, Michael Taylor's group. 1,000 medulloblastoma specimens were examined for their mutations and the importance of big data. So how can you analyze 1,000 specimens? You need bioinformatics and big data approaches, and that's what we did. Tatiana showed this earlier today, but that's the subgroups of medulloblastoma. Here they are listed here. And for those interested, this is all you really need to know about medulloblastoma into the 4 different subgroups: clinical parameters, the molecular features, and imaging, histology. Everything is on this slide as to the 4 different subgroups of medulloblastoma. And this information was not known 10 years ago, so it's an example of how far we've come. So I predict that in the future we'll be able to do diagnosis of medulloblastoma, have these different and then have specific treatment depending on which subgroup you are in as a patient with medulloblastoma. But right now, group 3 and group 4 medulloblastoma are the most aggressive, most malignant forms, if you will, of medulloblastoma and require the most treatment, whereas the Wnt is the least aggressive and requires probably less in the form of therapy. I'm going to move just for a moment to ependymoma. So this tumor is very common in children as well. And 10 years ago, we didn't know much about its genetics. We now know quite a lot. We also know that this tumor occurs in the supratentorial posterior fossa and spinal cord spaces. We also know therapy is not very effective. And the therapy is not very effective, and all these different drugs have been tried, is because we haven't understood the genetics of ependymoma until recently. So now we know that ependymoma, looking at many different tumor specimens and looking at 2 groups between Toronto and Germany, that ependymoma is really comprised of several different subgroups as well. And this is analysis that was carried out at Sick Kids Hospital. And now we know 3 different subgroups of ependymoma, and this is comparing Toronto subgrouping with Germany subgrouping. And the most important thing is that there's posterior fossa A, like for the posterior fossa ependymoma, A group and B group. So we can subdivide them into subgroup A and B in the posterior fossa, and that's important to know. And the reason why it's important to know, I'll explain to you in the next slide, but they have different outcomes and different treatment opportunities. So I think to summarize, group A has worse prognosis than group B for posterior fossa ependymoma, and also the location of it's different. Group A occurs more laterally in the Luschka CP angle area, and group B is more central tumors, and the invasion is worse with group A tumors than with group B tumors. And so they are clinically distinct, posterior fossa group A and group B for ependymoma, based on signaling pathways and genomic instability. The group B tumors for ependymoma favor surgical resection. So if you can remove the tumor, get gross tumor removal, and even subtotal removal, those patients are going to benefit from surgery. But unfortunately, for group A tumors, we don't have as good treatment strategy, and many of these children are going to fail and die from progression of disease over time. And these are the data from Cancer Cell. These are the 2 scientists, Michael Taylor from Toronto and Stefan Pfister from Germany, who discovered this 2 distinct pathways and 2 distinct types of ependymoma. So I won't describe this in much detail except to say that there are epigenomic alterations that occur in posterior fossa ependymomas. And it comes down to the epigenome. So these are alterations that occur on top of the DNA, not with mutations in the DNA itself. And because of that, we've been able to determine that ependymoma is a epigenetic alteration, and we need special epigenetic drugs. And these are some of the types of drugs considered for ependymoma that have never been used before. And the reason why chemotherapy has failed is because these drugs have not been tried previously. So in summary, for ependymoma, what you need to know is that it's an epigenetic disease. There's posterior fossa A and posterior fossa B. This is posterior fossa A, and new therapy is being tried now at Sick Kids Hospital to try to improve the survival of these patients, and another example of how big data have helped us understand this tumor. Diffuse intrinsic pontine glioma, this is how molecular genetics have helped us. This is the worst tumor that we see in pediatrics. This particular tumor is the result now of an epigenetic change that's been well characterized, and now we know that there are at least two different mutations. This particular mutation and this one, H3.3 K27, and H3.31 mutation, and these have implications as to whether you should do biopsies in the future. And just like for medulloblastoma, there were 4 papers published in Nature Genetics on diffuse intrinsic pontine glioma in recent times, and as a result of that, we've now come to understand the main mutations. An interesting mutation was found in this gene called ACVR1 in diffuse intrinsic pontine glioma. So with its discovery of the ACVR1 gene, we now know that this is activated and we can have targets for a new pathway for diffuse intrinsic pontine glioma and possibly treatment that has never been considered previously for this brainstem tumor, which is a very, very bad tumor. I'll just say a very few words about adult tumors. These are, of course, either secondary glioblastoma or primary based on the number and the sequence of genetic mutations that occur in these tumors. Of studies that have shown different subtypes for adult glioblastoma, classic, proneural, mesenchymal, and potentially these subgroups are druggable. But what's very interesting about these tumors is that we now know that there are some early treatments that can be used to try to improve the survival of GBM. And some of the emerging areas of interest for GBM in adults include signaling pathways of drugs that are being used now for the purposes of glioblastoma, the tinibs. These are all drugs that are being tried in phase 1 and phase 2 trials. Immune therapy, so vaccine therapy is being tried now for glioblastoma, and then agents to overcome the blood-brain barrier and deliver tumors more effectively using focused ultrasound as one strategy is being used now for. We've been using gold nanoparticles in GBM and delivering them to the advancing edge or the invading edge of glioblastoma multiforme using focused ultrasound strategies as a new way to try to treat adult glioblastoma multiforme in this article that we wrote in ACS Nano in September last year. Here's how molecular biology has helped us. All the different areas that we now know we can diagnose in the laboratory for various brain tumor types. We've heard about NF1 today. Here's GBM, stem cell replacement therapy, fluorescein in situ hybridization, methylation strategies, anaplastic oligodendroglioma. This is how molecular biology has helped us advance the world further. So in conclusion from this talk, personalized medicine and big data are being used frequently now for moving survival ahead for patients with various brain tumors. We are now approaching this with medulloblastoma and ependymoma. Pathways are likely easier to treat than all the genetic mutations because there are many more genetic mutations than there are pathways involved. As neurosurgeons, we're very interested in the novel technologies. I showed you some examples how we're using novel technologies to treat a variety of brain tumors these days. And then just to reiterate, because the repetition is good, big data, novel technologies, and personalized medicine will help us treat patients in the future. And with that, I'd like to thank you for your very kind hospitality once again and kindness to come back again to the Institute in Ukraine. Here's Konstantin, seen with Taras Mikitin, a neurosurgeon from Lviv, in Toronto during their fellowship lecture series that they came and took part in our program about a year ago. So we welcome again all of you to come back to spend some time with us. So thank you very much for your attention on that presentation. So Konstantin, Która zaraz godzina? Do we have time? One more lecture maybe? Okay, I'll go quickly through last presentation.
Around 45 minutes.
We have enough time? Okay. Any question on this last presentation regarding novel technologies, medulloblastoma? Okay, yeah. Question? Yes. Vadim.
Thank you very much for your amazing talks, yours and Diana, and thank you very much for the information on the consortium. We will consider our joining it. But my question is speculative. As we see, not only brain tumor but brain disease is characterized by very complicated pathogenesis, which is characterized by interrelations between multiple gene polymorphisms, mutations, multiple molecular pathways, interpersonal differences. So how could you describe your vision of ideal anti-tumor approach to fight cancer and to improve outcomes?
Yeah, so the question is, what's the ideal, what's the vision, what's the dream treatment for patients who have brain tumors? That's a very good question. Of course, right? If you had all the money in the world to study the whole genome and the including epigenetics, including the transcriptome and the proteome, and you could use big data and bioinformatics to sort through those millions and millions of data points, and if you could test them in a laboratory environment in animal models that were reproducible, you could theoretically have a personalized treatment for every different cancer, and that's what personalized medicine is, and I think that's the dream. But it's very expensive, and at the present time, nobody has the resource to do such a personalized treatment for all patients. But that would be the dream goal, is to try to analyze cancer down to a single patient and decide what treatment is best, not only at the time of initial therapy, but probably more importantly if there's relapse or recurrence, because we know, as was mentioned in previous question, that genetics are going to change for a recurrence of tumor. So, and then doing personalized medicine again for the recurrence to treat patients at recurrence as well, because likely different drugs are going to be needed at recurrence. So that would be the ultimate dream, is to have an individualized program for every patient. In absence of that, we have to pool data from large samples and try to predict how patients will respond based on data that is largely representative of one subtype that I mentioned of tumor or another. But that's not quite a personalized approach, but it's kind of a bulk data approach, which gives us some clues and probably is better than what we've been doing in the past. And that's also expensive, but it's manageable at this time. Okay, other question from that last talk? Yes, question here.
Thank you for an excellent speech. I just wanted to ask about stereotactic biopsy. What is your surgical technique when you want to figure out about the histological verification and about
So nowadays for stereotactic biopsy, we're not using frame-based, so it's frameless stereotaxy. So we would often use our neuronavigation system. At Sick Kids Hospital, we have both the Brain Lab system and the Stealth system that we are using for stereotactic biopsy. It's a very good question, because I'm going to be speaking about pineal region tumors next, and oftentimes it comes up, should you do biopsy of a pineal region tumor, or should you do open resection? So we'll come to that in a moment, but typically we're using frameless stereotaxy for biopsy. I also use ultrasound, like direct real-time ultrasound access to tumors, and will biopsy on the basis of ultrasound, which is a very useful tool for us. I would say that the number of cases we would just do biopsy for are limited nowadays, and Where it comes to be valuable, and I'll show you some cases in this next talk, is for diagnosis of germinoma. So for germinoma, you don't need to do big resection of tumor because we know it's exquisitely sensitive to chemotherapy, radiation therapy, so a stereotactic biopsy may be sufficient for a tumor like germinoma. So those would be indications if you strongly suspect germ cell tumor, doing a biopsy or marker study would preclude you from doing an open craniotomy as one example. Other question? Yes, question. Valerie.
Thank you, Professor, for your presentation. And I have one question about non-malignant tumor first grade. Do you use radiotherapy or chemotherapy after surgical removal of this tumor?
So what grade?
First grade.
Of astrocytoma? Or which?
Yeah, like ganglioma.
Oh yeah. So ganglioglioma, good question, Valerie. The question is, do you use radiation therapy for low-grade gliomas, perhaps like ganglioglioma? And in my practice, at least, for most children, ganglioglioma and other low-grade tumors is either surgical disease, so we must remove it as much as possible by surgery, or in places where it's impossible to remove low-grade tumor, like in the hypothalamus or optic chiasmatic pathways, we might try chemotherapy and try to avoid radiation in children as long as possible before thinking about radiation therapy. But then when children get to be teenager or adults, radiation for those types of tumors can possibly be considered. For children that have a diagnosis of fibromatosis, we try not to use radiation because they have a defect in repair mechanism after radiation therapy. So we would not treat initially with radiation therapy for children with underlying genetic disease with a low-grade tumor like neurofibromatosis. Yes, question here, Valdemir.
Professor, because I understand right, you said about using focus ultrasound for glioblastoma. What is follow-up of those tumors in such cases?
Yeah, so thank you, Volodymyr. I didn't explain in much detail for you, but basically what that approach is allowing us to do is to open up the blood-brain barrier. So we're not using focused ultrasound to kill the tumor directly, although you can treat a metastasis that's small. You can treat patients with Parkinson's for lesionectomy with focused ultrasound. I'm talking more about using intravenous delivered microbubbles that are then encouraged to expand in the capillary system within and around a tumor using focused ultrasound so that chemotherapy can be enhanced to the delivery of the tumor. Because one of the problems, as you know, with delivery of chemotherapy in the brain is the blood-brain barrier. So this is to break down the blood-brain barrier to allow chemotherapy to have higher concentration within the tumor itself. Okay, so I'm going to apologize at the beginning. It looks to me like these videos will not show, and I apologize for that, but I'll see if I can find some of these beforehand so we can pull those up. There must be some technical thing between North America and Ukraine video, so. Yeah, I apologize again. This one does not seem to go. Okay, so we found a way to show this one. Okay, that's good. So I'll show this one in a moment. And I apologize again. I don't know why the system is not working. So we'll talk now about pineal region tumor. And I do have some interesting videos. I apologize again that we're not going to be able to show maybe all of them, but some of them I hope we can show you. So I think for neurosurgeons in the audience, this is sort of the ultimate area of the brain in which we operate because it requires probably the most fundamental understanding of our anatomy And the challenges of getting to the pineal region really test us as neurosurgeons and our skills. And so if there are medical students or residents in this audience, this is the area I'm talking about, the pineal region. And you can see the anatomy here is extremely important. So here's the massa intermedia, here's the aqueduct of Sylvius, this is the tectum of the brainstem, here's the pineal gland, here's the splenium of the corpus callosum. But the most important thing I think you need to know is the venous drainage anatomy of the pineal area. So it includes, of course, the inferior sagittal sinus coming back to the straight sinus, but the deep venous system, including the basal vein of Rosenthal bilaterally, internal cerebral veins from both sides, the vein of Galen, and as mentioned, the straight sinus. So we have to work in and around. I have some video to show you of how we do these operations in the pineal area. So hydrocephalus, because it's close to the aqueduct, is very common, and these children will present with obstructive hydrocephalus. Paranode syndrome means inability to raise the eyes upward. Cerebellar signs can be frequent, precocious puberty, and pineal apoplexy, diabetes insipidus. But diabetes insipidus really means a child with germinoma who's got pineal plus suprasellar disease. So here are some examples of challenging tumors. I think you would all agree. Here's a child who's got both pineal region and suprasellar mass. This almost has to be germinoma by definition. PNET, as I described in one of my earlier presentations, and rhabdoid tumor, all occurring in this location. Differential diagnosis: germ cell tumors, pineal parenchymal tumors, glial tumors, non-glial tumors, and a whole host of other tumors can occur. Germ cell tumors are very, very common in Japan, and the reason why they occur in Asia more frequently is still not understood. Interestingly, females have a higher incidence of suprasellar region germ cell tumors than pineal, mostly in the males in the pineal area. And these tumors can be classified whether they're benign or malignant. And here's the host of the malignant germ cell tumors that we operate on many times. And there are tumor markers that help us make a diagnosis as to whether they're benign or malignant. So germ cell tumor markers, endodermal sinus tumors are positive for these, AFP and HCG. Same with embryonal carcinomas, choriocarcinoma positive for HCG. And these can be positive in the blood and in the CSF. Sometimes also you can measure them in the tumor. So here's an example of a child who had a pineal region tumor who presented with 9-year-old and double vision, paranode syndrome, and papilledema. So I'm sure that video is not going to play, but in any event, what do you do when you have this situation? And there was a question from the audience about biopsy, stereotactic biopsy. So in this case, rather than frame-based biopsy, we did endoscopic biopsy. And so we can also do endoscopic third ventriculostomy at the same time. So we would plan our trajectory so as to do endoscopic third ventriculostomy here first and then do biopsy of this mass second, because we were not sure what type of tumor this was. So with apologies, I'm almost positive this will not play. Yeah. So what we did is we biopsied, the tumor is shown here, and so we did endoscopic third ventricular biopsy, we did endoscopic third ventriculostomy, and the diagnosis of this case was a teratoma, so a benign tumor, mature teratoma. The approach that was taken was this approach, which was supracerebellar infratentorial approach. There you can see the thickened arachnoid and the veins that are located here. And here's the postoperative scan showing resection of the tumor that was removed through this approach. And because it's mature teratoma, the best treatment for this condition is surgery. There's probably no role for chemotherapy or radiation therapy if you can remove the tumor completely. And so we would advocate for surgical resection. We have many different approaches to the pineal region for tumors like mature teratoma: occipital transtentorial, supracerebellar infratentorial, and posterior interhemispheric retrosplenial, as shown in this diagram here, are ways that we can get to the posterior third ventricle and the pineal region. So there's an approach, occipital transtentorium, where we cut the tentorium, the tentorium, and we're able to get access to the pineal region. Is a very good approach for tumors that sit above the tentorium. For tumors that are largely situated below, we would use the supracerebellar approach, as is shown here. And then here's an approach through the ventricle. You can do subchoroidal approaches to the third ventricle and get that direction. And you can also use posterior transcallosal interfornicele approach. And I've used all of these approaches in various settings for pineal region tumor. So here's an 18-year-old female who had amenorrhea, Paranode syndrome, papilledema in the pineal area. What kind of tumor was it? How would you approach it? We used an occipital transtentorial approach and navigation and resected this tumor partially because at the time we got quick section report and this was the diagnosis. So you probably can't see it at the back of the room, but for those that know pathology, this is a germinoma. So when we got the diagnosis of germinoma, we could stop doing surgery, and we knew that this patient would be well treated by radiation and chemotherapy after the surgery, so we did limited resection of this tumor. Here's the postoperative image showing a nice resection, but this is one instance where you don't have to achieve a gross total resection when you have germinoma. Intracranial germinoma like this, you can see with some spread to the supracellar, and here's a synchronous lesion both in pineal and supracellar areas. And these patients are best managed, if possible, by endoscopic third ventriculostomy biopsy and CSF sampling. So here's an article recently published in Surgery on bifocal germ cell tumors, so pineal region, supracellar region, and these tumors can be approached in this fashion. And usually what we do is to make the diagnosis by biopsy, treat the hydrocephalus, and then get them on to further treatment. But bifocal disease, these patients tend to do quite poorly compared to those with focal disease for sure, and even sometimes those with disseminated disease. Here's an example. Again, I think I have a video here, but this patient had this kind of a tumor in the pineal area that you can see, but also coating the entire ventricle. And this was a 13-year-old male with raised intracranial pressure, and we did a biopsy and did a tumor endoscopic third ventriculostomy, and then we found that this patient was germ cell tumor responsive to chemotherapy, unlikely for video to play, so we did ventriculostomy right there. So this is a series from our institution, an older one, 20 years old now, but 51 patients, mostly pineal region tumors, 5-year survival, germinomas 85%, which is very good. But for the non-germinomas, a 45% survival rate for these particular tumors. We have preoperative localization and staging. We have CSF markers. Question about do you do biopsy versus surgery, open surgery resection. Again, for tumors that are in the pineal area, endoscopic biopsy and third ventriculostomy is a great way to treat the hydrocephalus, to establish a tumor diagnosis, and then come out with a plan for further treatment. Many of the germ cell tumors are chemosensitive to cisplatin and etoposide. Those are the two main chemotherapies for germ cell tumors. What about this tumor? Here's a tumor. You could approach this in any one of a number of different ways, but obviously in the pineal area, you could come this way, supracerebellar, you can come occipital transtentorial, you could come retrosplenial, you could come transcallosal interfornicele, between the two internal cerebral veins, you could come anteriorly. So with this particular tumor, this child had a brief history of papilledema and Paranode syndrome. We chose to do endoscopic third ventriculostomy, transcallosal approach, interfornicele between the two internal cerebral veins, and the diagnosis was pineal blastoma. Here's the postoperative, and what you can see from this sagittal image is the approach for our third ventriculostomy here and for tumor biopsy. And then when we went to take out the tumor, we came this way. So interhemispheric, posterior, internal cerebral veins, getting into the third ventricle and removing the tumor. You can see nice outcome. Here are the images from the screenshot at surgery. The approach has been taken through the callosum now, and now we're on top of the two internal cerebral veins. And then we've separated the two internal cerebral veins, and now we are in the third ventricle, and we've removed the tumor, and this child had pineal blastoma. So the treatment for pineal blastoma is really more aggressive. It's like a PNET treatment and requires chemotherapy and radiation. sometimes needs to have a second operation, and prognosis is a little bit guarded for these patients. That I showed you, this last example, child is still alive and well now after a resection of his tumor, now 5 years after surgery. Okay, here's another case, a pineoblastoma, very aggressive tumor. How would you approach this tumor? The neurosurgeons in the audience must be thinking about how they're going to tackle tumors like this. Very challenging cases. Do you need to do third ventriculostomy or VP shunting? That's a personal decision choice. This was occipital transtentorial approach, cycles of chemotherapy. Unfortunately, this child failed chemotherapy and had progressive disease and died because, just like PNAT, this is a very aggressive tumor. Another child with pineoblastoma, you can see here a solid tumor but some cystic areas. This is a child that we treated with occipital transtentorial approach, and this child is alive and well now many years after his treatment, but needed aggressive chemotherapy and radiation therapy as well. So here's the question, do you do biopsy or open resection? Biopsy may have sampling error associated with it, especially if it's a mixed germ cell tumor, you may not get all the different layers that are involved in the small biopsy that you take. So I think most of the times now for pineal region tumor, we'll try to do endoscopic third ventriculostomy and endoscopic biopsy. If we get enough tissue, that's great, but sometimes we may not, and we may have to go to open approach in any case. So what would you do in this case? Small tumor in this location. There's not much in the way of hydrocephalus in this case. Would you do a stereotactic biopsy? There's some data to show that a stereotactic biopsy in this region is a little bit more complicated, and the rate of bleeding from the surrounding vasculature is a little bit higher. So we may go to open approach for that case. That last case, so this case here, was pineocytoma. So this is a less aggressive disease than pineoblastoma. We try surgery where possible, and depending if there's any tumor left behind, we will treat with focused radiation therapy or chemotherapy, but it's not so effective for chemotherapy. So how do we avoid VP shunting? And some of these are videos that we'll not show, but this endoscopic third ventriculostomy. Here's the foramen of Monroe, of course, the anterior septal vein, the thalamostriate vein, the choroid plexus. This is anatomy that every neurosurgery resident must know. We know that tumors and aqueductal stenosis are the best indications for endoscopic third ventriculostomy. This is a study from the Canadian hydrocephalus group. Here's a good case for endoscopic third ventriculostomy, a child with a tectal brain tumor, so occluding the aqueduct here. And this is before and this is after endoscopic third ventriculostomy. You can see how the hydrocephalus has been treated, and there are way more sulci now after endoscopic third ventriculostomy than before. So I'll just, because I couldn't get this video, I'll just show you the nice anatomy. I'll just come out of this, and hopefully this one will play, and you'll be able to see the anatomy of this endoscopic third ventriculostomy from this one patient. So there it is. You can see that, I hope, a little bit better. You can see the pituitary gland. You can see the dorsum of the sella. You can see the basilar artery here. We're doing a little cautery on the back of the dorsum sella there. And then we'll be using tissue spreader to open up the floor of the third ventricle. And then we'll use sometimes in the past we've been using balloons. Now we're just using the tissue forceps to spread and make the opening because it's safer to do it that way. Here's a balloon. This was a technique that we used in the past, but you can see balloon technique being used to make that hole, and you can see the floor of the third ventricle pulsating with the heart rate after we're done successful endoscopic third ventriculostomy. So that's that case, and I'll just come down here as an example. We've had children that have had tectal tumors, and then after you do endoscopic third ventriculostomy, the tumors for some reason disappear. So this is before endoscopic third ventriculostomy, and this is after, to show the nice result that we get. But here's what was interesting. This was before, and this was after. Here's before endoscopic third ventriculostomy. You can see this enhancing tumor. And then after endoscopic third ventriculostomy, the tumor has gone away, and we have published this in the literature. So just the treatment of the hydrocephalus was enough to make the tumor disappear in about 5 cases, which was very interesting. Okay, so here's a case. I hope I have video for you. This is a pineal region tumor. I did this case last month. Toronto, 10-year-old female, had headache, double vision, Here's the CT scan showing a lesion in the posterior third ventricle pineal area here. So question is, what do you do? Here's the sagittal, here's the CT scans. You can see the CT venogram here showing the veins that are very important, and which approach would you use in a case like this. We have many different options. We did at first endoscopic third ventriculostomy and tumor biopsy, and the diagnosis of the tumor was papillary tumor of the third ventricle, which is a very rare tumor. So here it is, papillary tumor. There's the tumor located here. So we chose a supracerebellar infratentorial approach, and let's see, hopefully I can pull up video for this case. Yeah, so thankfully video is going to show. So looking up now, this is the venous complex that we see. At first, when you come supracerebellar, what you're looking at is the precentral veins of the cerebellum. So we're dissecting the arachnoid. The arachnoid's very thickened in this area, very thickened arachnoid that we're separating now and removing. And there you can see precentral cerebellar veins that need to be taken. We use a combination of sharp dissection and blunt dissection to break through the arachnoid, which is very thickened in this area, to get access to the posterior third ventricle. And then what we will do is central cerebellar veins that you can see there. And now we come upon the tumor, which we're debulking. You can see it's a fairly vascular tumor, papillary tumor of the third ventricle. And now we're lifting the tumor off of the tectum. So you can see the tectum is coming into view right here. And so we're taking the tumor off of the tectum and then mobilizing it, rolling it upwards, and then identifying the side walls of the lateral ventricle that you can see here, the third ventricle. And this is the papillary tumor here, and we're now taking its attachment to the side walls of the third ventricle, and then we'll take the superior vascular pedicle, which is here, and then the tumor will be removed, and the final diagnosis again was papillary tumor. So these tumors are very rare, and in many series of small numbers of patients, surgery is the best option. If you can't remove the entire tumor, then there's an option for radiation therapy, but it seems like from the literature, and I don't have much experience with this tumor, it's a fairly rare tumor. If you can remove the tumor, that's the best treatment strategy for such cases. So I think I have post-operative view here. This is now after that surgery. Here's the approach. This is just 2 days after surgery. You can see the approach that we took was supracerebellar. We've removed the tumor. This is axial, showing removal of the tumor from the side walls of the third ventricle. So this patient will get follow-up, will not need radiation or chemotherapy, and we're really hoping that tumor will not come back again for papillary tumor of pineal region. So in conclusion, we think about craniotomy and removal of many of these tumors in pineal area, stereotactic biopsy versus endoscopic biopsy we've talked about. So for example, in a mixed germ cell tumor, if you treat the malignant part of it effectively, the benign part of it might come back as a mature teratoma, and that's called a growing teratoma, and that might be a tumor that's amenable to surgical resection after chemotherapy is finished. Radiation therapy, we talked about. Some groups are using radiosurgery and adjuvant chemotherapy, mostly for the germ cell tumors that we talked about. We have room for markers in cytology, so HCG, alpha-fetoprotein, placental alkaline phosphatase are all used to help with diagnosis of germ cell tumors. If the ventricles are enlarged, we have a great opportunity for endoscopic third ventriculostomy, tumor biopsy to treat the hydrocephalus and to establish the diagnosis. If the markers are negative and the imaging findings are not typical for germinoma, we would think about biopsy after doing endoscopic third ventriculostomy, and open biopsy with small ventricles is possible, stereotactic biopsy. We can even do endoscopic biopsy when the ventricles are small, but you really have to be using either ultrasound or navigation techniques to make sure you're in the ventricle. Surgery, we're not sure That, I'll conclude this final presentation. And once again, this is Skyline from Toronto. I want to thank you for your kind invitation to be here once again to the Institute to give these lectures today. And I hope that this last talk on pineal region tumors will be important for members, that we can have discussion about management of these very challenging and at times difficult cases. And here's just one more illustration of our Ukraine Child Health Fellowship Program. Two neurosurgeons from Lviv who are here, Dr. Mikitin and Dr. Kuzik, who've come to Toronto. This is standing outside the operating room in the Children's Hospital, and they came to see many of our cases in Toronto, and we hope that one day in the future many of you too will have an opportunity to visit us in Toronto. Thank you very much for your attention. So, Kasi, we may have questions for pineal region tumor. Anybody have a question? Yes, question here.
My question is about diagnostic test, blood levels, and fetal protein and protein in patients with terminal tumor. How often do you use this test?
So every case we will do where there's a pineal region tumor that looks suspicious for a germ cell tumor, we will do. And we now have the capability to do both blood and CSF testing quite rapidly in our hospital in Toronto. I don't know how easy in Kyiv it is for you to get results from alpha fetal. Get it within a day or two, so it's actually pretty helpful for us. But the best strategy is to do serum marker first, and if serum marker is very high, you maybe don't have to go to biopsy of tumor, but if there's hydrocephalus, then it's not a bad idea to do endoscopic third ventriculostomy, tumor biopsy, because you might have mixed germ cell tumor, and it would be really nice to know if you're dealing with endodermal sinus tumor, if you're dealing with one of the other mixed germ cell tumors, HCG secreting tumor, choriocarcinoma. It would be very nice to know what type of germ cell tumor you are dealing with before you get on with chemotherapy. But most of the time with elevated markers, we know that that's a disease that will be treated by chemotherapy and radiation. And if after there's residual disease or progressive disease, surgery might be indicated in the form of open operation. Okay, other question at the back.
Thank you for the presentation. I want to ask about your opinion about if we have first time diagnosed pineal area cyst, and what must be our tactic of diagnosis, and how often must we perform MRI control or other procedures?
Yes, so thank you. Question is about pineal cyst and what do you do about pineal cyst. So small pineal cyst in a child with headache is sometimes problematic, but in most of the instances, those children don't have any form of hydrocephalus. So it's a small cyst that's seen in the location of pineal area, and most of them are considered benign pineal region cysts. And I usually follow those patients with MRI scan once a year. If they have headache, I will have them see pediatric neurologist for headache consultation and see if that makes the children better. I have never, personally, I've never operated on child with pineal region benign cyst. These cysts can be complicated, so you could have an atypical cyst that has both solid and cystic components to it, and those patients need to be followed more closely with MRI scan, maybe every 3 to 6 months, and marker studies to see if they're abnormal, because occasionally those children will progress and end up with disease that will need to be treated. Just in the last month or two in the Journal of Neurosurgery, we published an article from Australia on a fairly controversial approach to pineal region cyst, where the neurosurgeon used an open surgical approach to treat the cyst because the patients were having headaches, and it was claimed that the headaches were much better after the cysts were treated. There were many editorials written about that article, and so our main conclusion from pineal region cysts is that they rarely require surgery. If they're atypical, you must follow them more frequently with MRI scan, and occasionally some of those patients may have progressive tumors that require treatment. Yeah, question here.
Thank you very much again, Professor.
Yeah, so we have a prophylactic antibiotic protocol at the hospital for sick children that's followed with every case, and that's to deliver antibiotics at least 10 minutes before the operative exposure is begun with surgery, and that's pretty standard in our hospital plus across many institutions in North America. We have this checklist. We have a timeout, it's called, before surgery, where antibiotics are delivered routinely for every neurosurgical case, no matter how big or small in many ways. So for endoscopic treatment, follow the same kind of protocol. For external ventricular drain, if we have an external drain in place, I am treating daily with antibiotics prophylactically until drain is removed after 24 hours. But not every neurosurgeon in North America is doing that. Many don't believe you need antibiotics in such cases, but I personally use antibiotics for externalized ventricular drain. And I would say that I've not had any major problems using antibiotics over that length of time, sometimes, as you know, 5 to 7 days. And we know that the longer a drain is in place and you don't use antibiotics, the higher the risk of infection. So I personally treat with antibiotics routinely, prophylactically in external ventricular drain situation. And for our shunt patients, if we're implanting VP shunt for sure, we are following the protocol for preoperative antibiotics. And we use ANSEF, which I don't know what the equivalent in Ukraine, but it's some cephalosporin, second generation cephalosporin we are using. Yes, Valerie. Yeah, so the question is about some tricks for supracerebellar approach. So I'll show the video again because it helps me talk through some of the tricks. So basically, we do not use sitting position. Maybe in Ukraine, do you use sitting position? Somebody, yes, sitting position? Anybody sitting? No. So we almost never use sitting position. So some people say that's a trick because the cerebellum comes down and you can go above the cerebellum more easily with sitting position, but we never use rare in North America, certainly in Toronto, we have not used for 25 years for sure. But it's good to have brain relaxation. The cerebellum must be able to come down. So we open up the cisterna magna first, right? And you let the CSF out so the cerebellum can come down. That's one trick to remember. And then we use typically we use the central approach over top of the cerebellum in the midline. And you may see more than one precentral cerebellar vein, but we try not to go too far lateral to take too many veins away from the central corridor because you only need the central corridor. In this video, you can see we're not using self-retaining retractor. Some groups say to use self-retaining retractor, but we don't use. If you have CSF relaxation, if you have opportunity for cerebellum to be gently displaced, that's better because I think fixed retraction will lead to some cerebellar edema and some problem with cerebellum afterwards. Most of the axis is central. I know that the approach from the side, you mentioned the lateral trajectory is used in some cases, but not for small central tumor like this. I think it's much better for big tumor in the pineal region. A lateral approach going across the lateral side of the cerebellum is very good. And then one of the big tricks is to identify your anatomy. And for many of these benign tumors, you can identify this clean margin. So I think you can see there how we're able to get the tumor off of the tectum. It's coming off very nicely to define that plane. And same thing with the plane, the lateral wall of the third ventricle. Always look for those planes and try to define them because that will help you stay out of trouble and determine whether you can remove these tumors or not. But if the tumor is infiltrating either the thalamus or the tectum or other structures nearby, we do not go and suffer neurological consequences as a result of that. So like almost neurosurgical oncology everywhere, develop the plane around the tumor, try to find the margins, and then remove the tumor as safely and as quickly as possible. Try not to use so many self-retaining retractors, and certainly try to take as few veins as possible, because we know that venous infarction can result, and there can be problem with injury from just venous stasis if you take too many veins. Okay, other, yeah, please.
Do you routinely use the esophageal sensor for the embolic protection system?
Yes, so it's really in the hands of the anesthesiologists, and they have the technology to do that very simply nowadays. But because we don't use sitting position, and because we're not so worried most of the time with air embolus from air getting into venous sinuses with such cases, we don't often need esophageal monitor. For this case that we showed you, this supracerebellar case, we actually took off the bone above the transverse sinus, so the entire transverse sinus and torcula was visualized, which allowed us to hold the dura up, and we put a stay suture into the tentorium also to move the tentorium up as another trick to see as clearly as possible, as superior as possible.
Thank you for your interesting speech. I have a question. When you're doing the surgery and using occipital transtentorial approach, do you often have some complications like loss of vision, hemodynamics? Do you have some maybe methodics of prevention?
Yeah, so question is occipital transtentorial approach, and there the mesial occipital lobe is in jeopardy of having retraction injury. I think a couple of things come to mind. One is, again, trying not to use a self-retaining retractor that has too much pressure on it, because that will cause injury. Second thing is to position the head, and so I didn't show a case, but if we did occipital transtentorial root, we would do park bench position with the patient's head turned 45 degrees or 60 degrees to the floor, and then we would operate on the side where side to allow the cerebellar hemisphere to come away from the falx by itself by gravity, to avoid any unnecessary edema or injury from retracting on the mesial lobe. But in our experience in children, problem, we've not seen any permanent visual field deficits just from the occipital transtentorial approach. And something to remember is that in the occipital corridor, there aren't that many draining veins. Most of the veins are, as you know, further up, draining the occipital parietal junction, but the actual mesial occipital pole has very few veins, if any. So you can retract there very nicely without taking veins and worrying about a venous injury. A question at the back.
I have one more question. Do you always use endoscopic third ventriculostomy in case of annual region tumors with hydrocephalus, or are there any cases when VP shunting is more preferred?
Yeah, so the question is about choice of endoscopic third ventriculostomy versus VP shunt in these cases of pineal region tumors. So I think it comes down to the age of the child in whom the diagnosis is. A young child with pineal region tumor under age 1 year, that seems to be the cutoff for us to use VP shunts. So we would typically, in that age group, think about putting in a VP shunt first and then dealing with the tumor. We can sometimes third ventriculostomy, but we know in the very young child that it's going to fail more often than if we have older child. So on occasion we'll use VP shunt, but it's usually based on the age of the patient. But if we can do endoscopic third ventriculostomy in older child and can avoid a shunt, it's much better, because then complications related to chemotherapy, immune suppression, shunt infection. Thank you again for your attention.
Сьогодні ми завершимо перший день в інституті. То був день лекції. Завтра, наступний день, то буде день практичний. Тобто професор буде проводити показову операцію в клініці, і ви також зможете, якщо бажаєте, прийняти і подивитися, як це проводиться на сучасному рівні. Що я хотів би сказати під час нашої сьогоднішнього завершення першого дня. По-перше, ви бачите, що нейрохірургічна спільнота і провідні нейрохірурги світу від молодих нейрохірургів України. То є перше. По-друге, ми намагаємося зробити так, щоб в нашому інституті проходили лекції, вони стали регулярними, вони проходили на постійній основі. І ми залучаємо наших фахівців, залучалися, слухали ті лекції, які проводять наші видатні фахівці нейрохірургії.